السلام عليكم.
عليكم السلام ورحمة الله.
طيب، متى ما حبيتوا نبدأ أنا جاهز.
السلام عليكم. First, I'd like to welcome Dr. Rakan, who's a consultant cardiac surgery in King Khalid University Hospital. Thank you, Dr. Rakan, for your contribution. Usually, we are four graduating residents. I can see now two only joining. The rest, inshallah, will join soon. But we can start if you wish.
طيب، على بركة الله. شكرا دكتور فيصل، وبالتوفيق لكل الأطباء المتقدمين على اختبار البورد. يعني بداية والله ما شفت English now. So basically, I think the format of this lecture is I really hate giving very didactic, comprehensive summary lectures at the level that most of you are in right now at the senior level, you're past beyond this. So what you need is you really need to cultivate and combine your knowledge in a way that is comprehensive for you to process it and present it in a rational way during your exam and hopefully shortly after in your real life practice. So I was given two topics. Sorry, yesterday I had a emergency case, so I couldn't really commit to giving the lecture or the talk. Now I'm given the cardiopulmonary bypass setup and what have you, and then mitral valve diseases. What I would like and how I would like this to be, I would like it to be interactive. Now, as much as you can do interactive on Zoom meetings, I really, really despise and hate Zoom meetings. But unfortunately, it's the most convenient way nowadays to conduct such sessions. So I would urge all of you to please participate, especially the residents who are about to do their exams, because this is going to be exam-based scenario. And let me, being part of these committees that conducted the exams over the last few years, I'll tell you, the scenarios, the ones that you will be examined in are taken from our real-time practice. So basically, they will ask me to prepare a mitral case or a coronary case. And I will think of the closest case that I had over the last few months or weeks and present it. So basically, at the end of the day, the exam is going to be based on real life structure and real life scenarios. It's not going to be something that is going to be very academic. It's going to be real life. And most of you, the people who are examining you are not purely academics. They're practicing cardiac surgeons who want to hear real life scenarios and practical answers. With that, without further ado, I'm going to proceed with cardiopulmonary bypass. So now, one of the things, we take cardiopulmonary bypass for granted because we have a perfusionist most of the time. They're senior perfusionists. I know when I started practice, most of the perfusionists I worked with were perfusionists even before I entered medical school. So we take it for granted that we have very experienced, highly trained people running the pump for us. And all we need to focus on is just how to cannulate, conducting the procedure and coming off bypass. But honestly, over the years, what I realized is having established a few cardiac surgery programs inside the kingdom and outside in the private sector and in the government sector, I got to work closely with perfusionists. And there are so many things that I became aware of that I wasn't aware before when I was in training and even when I started my practice. And I think it's worthwhile for all of you to spend a day or two with the perfusionist, just seeing how they set up, seeing the equipment that they use. When you're asked to establish, some of you will start their cardiac surgery program on their own, solo, in a remote area. And you really have to understand how to get the equipment, how to set up the equipment, who to call, and so forth. So and this is an open question, especially for our residents who are about to do the exam. What are the components of the heart-lung machine?
So I'll start from arterial cannula, then tubing line.
Excellent.
Venous reservoir, oxygenator.
Okay.
And filter, and the pump itself, it's either roller or centrifugal. Yes, the venous line and venous cannula. This is the main pump.
Okay. So Faisal, you gave me exactly what a typical cardiac surgeon would give based on the illustration of the cardiopulmonary bypass. But if you ask a perfusionist, he's not going to think in the same way that you illustrated. He's going to think in terms of how the pump is set up in terms of packaging and the way they get it from the company. So I can tell you that the pump has 3 or 4 main components. First of all, you have the pump, the heart-lung machine. And most of us now use, in our routine cases, ruler pumps. Centrifugal pump have fallen out of favor for conducting open heart surgery. They're used now in LVADs and ECMO, especially ECMO. But to conduct open heart procedure, they've fallen out of favor. So most of us use ruler pumps, and it's the S5 manufactured by Mackay, a German company. So you really have to understand that you have to have the pump, and the pump usually has a couple of ruler heads, usually four, at least four. No, I mean, some of them have more, but you usually have 3 to 4 ruler heads. So you have the pump, and then you have the components that you purchase from the company, and they are the custom pack. What is the custom pack? Is basically the lines and the tubings and the filters and everything that you set up, that the perfusionist, not you, the perfusionist setups. There's the custom pack, there is the oxygenator, and there is the cardioplegia. Now, all of these come separate. So when you ask the perfusionist to set up, they're gonna basically open 3 packages: the custom pack package, the oxygenator package, and the cardioplegia package, and set them up. Now, added to that is from the nursing side, the cannulas are prepared on the table, the venous arterial cannula, depending on the preference of the surgeon, LV vent, and the antegrade or ostial cardioplegia or whatever. So basically what you have is you have the cannulas from the surgeon's side. You have the custom pack, which is the tubing, the setup. And by the way, the custom pack, usually there is a drawing that is specific for each hospital and each preference. The size of the tube, the connectors, how you set up the pump is you put the filter in the beginning or at the end. You combine the venous reservoir with the oxygenator or the filter with the oxygenator. These are all different, and this comes with the custom pack. And then you have the oxygenator, and then the cardioplegia usually is a separate setup. So basically, you have to really be aware and cognizant of these, because when you start your own practice, you at some time will have to, as the surgeon, unfortunately, will have to communicate with the companies to purchase these setups and communicate with your perfusionist to start a routine case. So this is okay. So we've talked about the components of the heart-lung machine. Now, what are the steps for you to go on bypass?
So you have cannulation.
Okay.
You have anticoagulation, so you have to make sure that you're anticoagulated.
Absolutely.
And make sure that
okay.
you're anticoagulated.
So the anticoagulation. What is the level of anticoagulation, and how do you measure anticoagulation?
So you measure your anticoagulation with ACT, activated.
Why not PTT? Why ACT?
Because it's more readily available, and it's quicker, so you don't need to send to a lab or anything like that. You have your ACT machine right in front of you.
Excellent. But sometimes when you want to calibrate your ACT, you will send it to the lab just to make sure. Or sometimes, and believe me, this has happened, where the ACT machine will break down and say only ACT machine that you have available in the operating room. So unfortunately, you will have to send a sample to the lab to get a PTT in order for you to start your case safely. What is the level of ACT that you require to go on bypass?
Safely or
safely.
What's typically said is 480, but usually if you need to, over 400 or even in some cases over 350 could be accepted.
Absolutely. That's correct. So basically, I mean, the textbook answer is 460 to 480, but anything up for me in my books, anything above 400 is safe as an initial start. And then you have to repeat the ACT every 30 minutes, 20 to 30 minutes, just to make sure. And if it's coming down, you might need to augment with a bolus of heparin. So what's the loading dose of heparin, the initiating dose of heparin for you to attain that level of ACT usually per kg?
It's usually 400 maybe 300 to 400 units per kilo, but usually I think we give 400.
Great, great. So basically you give that initial bolus, 300 to 400 units per kilogram, and then check your ACT within 10 minutes. And if it's above 400, then you're safe. You're probably safe to go on bypass and initiate your case. So what happens if you give heparin and the ACT would not budge? What would you expect the issue here?
The expected issue, heparin resistant.
Yeah.
Why?
Antithrombin 3 deficiency is one reason.
So so what is the mechanism of action of heparin as a molecule?
Indirect, through activation of the function of the antithrombin 3.
Excellent. So, and where do you find antithrombin 3? Antithrombin 3, where is it? Where do you find it? Do you find it in the platelets and the RBCs and in the brain and the heart?
FFB, you can.
Okay, in plasma, basically. So it's a component of plasma. It's a natural antithrombin, as the name indicates, is a natural anticoagulant. In our circulation, you have procoagulants and anticoagulants, and usually there's a hemostasis or homeostasis. There's a balance between the two, the fibrinolytic system and the coagulation system. So these are naturally occurring in our body to keep our homeostasis. So what you do is when you give heparin, you actually override this by potentiating the action of antithrombin 3. So sometimes when you have depletion of antithrombin 3 in the plasma due to previous heparin exposure. And in order for you, especially for patients who've been in hospital for a long time, they've been giving DVT prophylaxis, sometimes full anticoagulation. So they come to the operating room with depleted antithrombin 3 in their plasma because they've been exposed to heparin. And how do you fix this in order for you to go?
You can first give second dose heparin.
Okay.
If failed, you give FFB.
Okay. And again, the rationale for giving FFP is you are introducing more antithrombin 3 so that your ACT can go up. Okay, so this is in terms of anticoagulation. Now, you will be faced rarely with patients who have HIT. And can somebody explain to me the pathophysiology of HIT?
Yes, actually, we have HIT type 1 and HIT type 2.
Okay.
HIT type 2 is immune mediated, as in
exactly. And this is the one that concerns us. Type 1 is basically, it's just a low platelet count, but type 2, I'm more interested.
There is a direct effect of heparin with reducing the platelet count, basically, which is type 1, but it's to a lesser extent. But the immune mediated one, which is type 2, is induced by the heparin factor 4, platelet factor 4 complex, which further reduces the platelet by activating them and increase the release of further factor 4, platelet factor 4.
Okay, which is platelet factor 4 is what?
It's released from platelet itself.
And what does it do?
It's an inhibitor for heparin.
And more importantly, it's very thrombogenic.
Yeah, because it activates more platelets and causes aggregation.
Exactly. So it activates more platelets. So basically, you have more release of platelet factor 4, more aggregation platelet. And this is what you get clinical HIT. It's basically clinical HIT is when you have thrombosis, mostly on the venous side. And there's a criteria for HIT syndrome. So let's suppose somebody who needs CABG now, you're called for a triple vessel disease patient and he needs CABG. You do your routine workup and found that his platelet count is low, less than 50% of what is expected. Let's say his platelet count is basically, instead of 150,000, is basically 60,000 or 50,000. What would you do?
If patient not emergency, you can delay surgery.
Okay, but before you delay surgery, do you have any? Do you want to investigate? Do you want to know why the
Yes,
platelet
I will
count?
do for him a blood test for detect antibody.
Okay, so you want to do a HET screen.
Yes.
Okay, and let's suppose the by the way, sometimes the HET screen is inaccurate. So the most accurate is so the one that we do in most hospital is ELISA, but there is another test. I forgot the name, but it's I think it's only available in a handful of hospitals. If somebody knows the name, just remind me.
Serotonin.
Serotonin release test. So this is the confirmatory test. So the HIT antibodies, sometimes there's cross-reactivity of antibodies. So if you have HIT antibodies, that doesn't mean that you have actually clinical HIT. It just can be just a cross-reaction. But the serotonin release assay is basically the confirmatory test. And I think here in the Kingdom, it's only available at King Faisal Specialist Hospital. But anyway, let's suppose you do a HIT screen and it is positive. You have HIT antibodies and the patient is elective. What would you do?
I can give him a shot heparin for test.
No, sorry, Ilan. So again, I'm gonna focus on the scenario. Antibodies are positive. You know, you were concerned, you were planning to operate on the patient on the same admission, and you find that his platelet count is low. You send for HIT antibodies and the test comes positive. What do you tell your patient?
Does he require an emergency or urgent surgery or no?
No, it's a purely elective, triple vessel disease, stable. Patient's not having any active symptoms.
I will explain for patient. Patient
And
needs surgery.
what would you do?
I will delay surgery after.
For how long?
At least 1 month.
No. If you are waiting for the antibodies to wear off, it's around
3 months.
6 months.
The best 3 months because the antibody level going down after 3 months.
Dr. Al-Hanouf, what's the time frame?
It's 6 months for the average antibodies to wear off.
What's the time frame? Sorry, this connection is not clear. How much?
It's around 6 months for the antibodies to wear down.
So
3 months.
basically, I mean, 6 months is a bit of a stretch, but usually we wait for 3 months. So, you know, they say, you know, 6 to 12 weeks for the antibodies. And then what do you do after let's say 3 months or 2 months even? What do you do?
I would repeat the
Antibodies.
Yeah.
Okay. And if it's negative, then proceed with how many shots of heparin?
Single shot, only 1 shot.
Single shot. Okay. Because how long does it take for the HIT antibodies to reoccur again after re-exposure?
I think it's this after re-exposure. I think it's around 4 days.
Exactly. So, and first time exposure, how long?
14 days.
Yeah.
14 days. So you again 4 and 14. So for first time introduction, so 14 days from the first time of exposure to heparin, you might develop HIT antibodies. For re-exposure, you have a window of 4 days, and usually you can only give heparin once. Let's suppose on a rare case that you need to operate urgently, and the patient cannot wait during the same admission, and you have HIT antibodies in the system. How would you proceed?
We can use other anticoagulants such as hydrodines or argatroban.
Okay, excellent. So basically, in these, try to avoid operating on these patients at all costs. Even with Herodin, argatropan, and all of these NOACs or novel anticoagulating agent, the efficacy is inconsistent, unlike heparin. And you really have to work closely with your hematologist and clinical pharmacist to really find the dose adjustment. And unfortunately, you cannot rely on the ACT. So you have to really sometimes send either INR or PTT in the lab, which takes time. Again, I've seen situations where some surgeons were keen on operating on such patients, and unfortunately, despite all the efforts that were done, the case ended with a pump thrombosis or a catastrophic clot in the brain or in other vital organs. So, I mean, if your hands are tied, then just know that you have argatropan or Herodin, and the dosing, I don't think you have to remember the dosing for the sake of your exam. I just say you would work closely and coordinate with your hematologist and the clinical pharmacist to find the dosing and the measurements. All right, I think this covers most of the basic setup that I want to talk about heart and lung machine. Now, I just want to present a few scenarios of pump catastrophes and pump emergencies. And believe me, no exam either here, North America, or any other place in the world is ever complete without having a pump catastrophe scenario. All of you, unfortunately, if you practice long enough, you will have one or a couple or even all of these disasters happen, on your watch. So learn from the mistakes of others and be prepared, because when they do happen, it's really, the life of the patient is at stake and your reputation is at stake. So let me start with, so a typical scenario that will always happen in the exams, and you will get asked of it. So you are on cardiopulmonary bypass, and let's say you're doing a routine CABG, and you just went on bypass. You haven't put the cross clamp. You ask for the cross clamp. You're about to put the cross clamp, and you look at the arterial cannula, and there's air bubbles coming down the arterial cannula. What do you do?
I will stop pump.
Okay, stop the pump. And
Head down.
Head, excellent. Excellent.
And,
And then, so stop the pump. So you have to stop, it's air, stop the pump, head down, call for help. And then what do you do as the surgeon?
I will, after that, remove the cannula.
All right, okay.
Then you can place aorta cannula in the SVC if you can do retrograde.
So you remove the cannula, you're just going to keep it hanging in the air?
No, squeeze.
Squeeze or what?
De-airing.
The air. Okay, so again, there's air. There's a problem in the circuit. There is air in the circuit. So you took out the cannula. Now, when you take out the cannula and the head down, there's going to be a bloodbath. That's fine. Again, this is a life and death situation. So you take the cannula out and you de-air the cannula. So ask the perfusionist to circulate and get all the air out. Usually you give that to your assistant. So you're focused now on the aorta that's bleeding, and you are trying to cannulate the SVC. Yes. Okay, and so you cannulate the SVC. What do you do next? So hopefully by the time you cannulate the SVC, all of the air is out. By the way, what do you cannulate the SVC with?
Retrograde cannula.
Okay, that's fair enough. I think the retrograde is small, versatile cannula that you just need to do a quick purse string in the SVC and insert it in the SVC and hook it up to the cardioplegia line. And then, okay, so let's suppose you de-aired, you cannulated the SVC. What do you do next?
I'll start the retrograde perfusion, and I ask the perfusions to start cooling.
So what's the pressure that you want in your retrograde?
So maximum of 30 to 40.
Excellent. Okay, so usually 30 to 40. And what's the blood temperature called?
I'll cool to till 18.
Okay, again, you're not going to cool because you're not on systemic cardiopulmonary bypass, but you're just giving retrograde cold blood to the brain to wash out any blood from the arterial system in these inside the head to come out through the jugular veins. Okay, how long do you flush the brain?
For 3 minutes maximum.
Okay, so a few minutes. You don't need long, but hopefully enough time for the bubbles to come out of the brain. And then what do you do?
I will watch the air if there's air coming from the arterial cannula.
Trust me, you're not going to see any air, but you're going to see just red, dark blood all over the place. It's a bloodbath. But again, you've given some retrograde blood, and then 3 minutes, 4 minutes, whatever. You've given some blood. Hopefully, you see some air bubbles. I doubt that you will. And then after that, what do you do?
Again, recannulate arterial cannula.
Excellent. And what?
Resume the cardiopulmonary bypass.
At what? What temperature?
Again, with cooling, aiming for 18 or 20.
Okay, good.
Same time.
For how long?
Half an hour will be good.
Okay, so how long? How long? There's no time frame. You basically finish your case. Remember, you came to do a case, not to treat air embolism. So finish your case, be it a cabbage, a valve, or whatever, and then reworm. And then some people advocate keeping the patient sedated for 24 to 48 hours by thiopental. Some people say just wake up the patient and see what happened. Again, I do encourage all of you, please memorize the scenario because this will happen. Don't wait for the examiner. I mean, I'm usually, when I'm examining people, I do give them hints and try to extract information from out of them. Most examiners will just be mask face, and there will be a very odd pause. And so just make sure that when you're talking and giving the answers, that it just flows out of your brain and out of your mouth. Don't wait for the examiner to start asking you questions and extracting information, because that will deduct some of the points from your exam. Okay, so this is air embolization. Another scenario is you cannulated, you went on bypass, and the perfusionist will say, let's say you cannulated, you went on bypass, your perfusionist said everything was fine, you put the cross clamp, and the perfusionist all of a sudden will say, I'm having high pressure in the arterial line. What would you do?
I will check in the arterial line, maybe clamp or kink.
Okay, good. So that's a good stuff. So start checking anything technical. Is there any the cross clamp sometimes can catch the tip of the cannula inside the aorta. Sometimes the cannula is kinked, and sometimes the cannula is just in opposition, hitting the wall. So just adjusting the position of especially the long flexible cannula, you just pull it back and the pressure will improve. Let's say you did all of this and the pressure is still not improving. And then you look and the aorta is swollen and has a, what do you call it? A pink color. Not pink, what do you call it? Violet color with a mauve.
Blue color.
Blue color.
Blue, yes. Okay, I will stop the pump.
Okay, immediately. Can you stop the pump immediately if the heart is cross-clamped and arrested?
I will decrease flow and remove cross clamp.
Okay, طيب بعدها. You have to wait for the heart to start.
The pump.
You cannot stop the pump.
Wait for heart.
So wait for the heart. If the heart is not beating, you can do open heart massage. So, but again, if you so what are you suspecting now in this particular scenario?
Maybe dissection. Aortic dissection.
Okay, most likely. So a mottled aorta, blue color, swollen. It's most likely now the cannula has caused a dissection that extended retrogradely or antegradely. So in that case, you really need to stop the pump as soon as possible. Can you stop it as soon as possible? Well, you know, if the heart is working, that's fine. If the heart is beating and ejecting, you can stop the pump anytime. But if the heart is flaccid, then you cannot. If you stop the pump, you're gonna lose the patient. So you really have to come down with the flow as quick as possible. Take out the cross clamp. Try to hope that the heart can be started and revived as quick as possible. If not, you can do open heart massage until you what? So you said you're gonna stop the pump and
stop the pump and switch to peripheral cannulation.
Excellent. Switch to peripheral cannulation and then
calling the patient.
Do you need to call the patient?
Yes, I will call the patient.
You're going to replace the ascending aorta? You're going to do arch replacement?
Yes, I will do TE. We'll check.
Okay, fair enough. Okay, so most of the time, iatrogenic dissection is treated by removing the cause. So once you remove the cause, most of the time dissection is fine. So you really don't need to replace the ascending aorta. Just change the cannulation site and resume your case as you intended and do some imaging. I would agree with you. And if there is a dissection extending to the ascending aorta, then by all means, it's not unreasonable to replace the ascending aorta. But most of the time, iatrogenic dissection is if you fix the cause, then most of the time it's self-limiting. Okay.
Dr. Rakan?
Yes.
I have one question, if you don't mind.
I've
read in one source regarding this issue, and they stated that one way of dealing with this scenario is instead of peripheral cannulation is directly cannulating through the dissection flap using a Seldinger technique.
So again, this is a technique that's, even with acute aortic dissection surgery, instead of going axillary cannulation or peripheral cannulation, you cannulate through the dissection, through the flap into the true lumen. You have to have a good TEE and reliable TEE to guide you through the false lumen and into the true lumen and go through the flap. I think it's reasonable, but again, most of the time, you're not going to have the luxury of TEE. And if you do have it, then you need to really make sure that whoever is operating the TEE is somebody who's really experienced who can guide you. I think the safest way and the most reliable and reproducible way is just to say, I'm going to cannulate peripherally. You're not going to be able to do axillary cannulation, not only because it takes time. You haven't set up for axillary cannulation, it's not prepped, but a femoral cannulation is very accessible and easy to do and doesn't take time, especially when you're in these very tight situations. Okay.
Dr. Rakan,
yes.
What if you were not able to cannulate the femoral sites because of whatever reason, such as extension of the dissection? What other choices do you have if you don't have a proper echo technician, or would you rely on your anesthetist to do the Seldinger technique at the distal arch or somewhere else? Or what other choices do you have?
Yeah, you can. I mean, sometimes you can cannulate the innominate artery if it's not dissected. You can find a spot in the arch where you can go through the dissection. Now, I know I spoke to one of my friends in UPenn, who's a very well-established aortic surgeon, and he said he doesn't even rely on TE. He goes by feel. So he will put the needle, the Seldinger needle. He said you will feel one pop through the wall, and then the second pop through the false lumen into the true lumen. He said he just goes by feel. I haven't done it. I really don't advocate doing it personally, because there's far too many things that can go wrong with this technique. But the fact is, this is very rare. This scenario will happen rarely. And I mean, even if the femoral arteries are dissected, when you open the and even I've done it with the axillary artery in acute dissection, is you will see the dissection, but once you open the vessel, you will see that there's a flap inside the vessel. You just open through the true lumen. I mean, the true lumen can be clearly visualized. I mean, you will see a dissection and you will find the true lumen and put your cannula in the true lumen. That's all you need. And the same thing can happen with the femoral arteries. You will find a dissection flap. Just open the dissection flap and go through the true lumen. I think that's easily doable.
What about Dr. Rakan, the brachiocephalic cannulation? What cannula do you prefer to use, and how to direct it, basically, in the?
The best cannulas I still prefer are the IOPA cannula by Medtronic, or the flexible arch cannulas. They come in all different sizes. They come from size, I think the smallest is 18, and they can go to up to 22 millimeters. They're very low profile, very flexible, and they go in easily. So, and you can put them percutaneously, provided you use a dilator before. So there's a specific dilator for peripheral cannulation, and you can insert it percutaneously. The other arterial cannulas that are available, I mean, you have all sorts of the curved tip cannula, which I hate because it's rigid. I think, as you develop your practice, you will find the preference. But by far, I find the IOPA cannula, or the flexible arch cannula, to be the best.
I should direct it towards the brain, or down towards the arch?
If you do brachiocephalic, no, I wouldn't direct it through the brain. I would direct it through the arch, to the arch, because if you direct it to the brain, you're just gonna cause brain edema. If you're giving all that 5 liter, 6 liter blood flow to the brain. Which reminds me, by the way, and this is again unrelated to disasters, but how do you ensure that your flow is adequate on bypass? Or usually, what does your perfusionist?
So ask about the flow.
Okay, how does the perfusionist calculate the flow?
So depend on the body surface area of the patient.
Excellent. And usually, what's the index that you want the perfusionist to achieve on cardiopulmonary bypass?
2 to 2.5 liter per.
Okay. This is at what temperature?
This is at the normothermia.
Normothermia. So the lower the temperature, you can reduce your flow. You don't need as much flow because, again, the oxygen consumption in the body. I didn't discuss these facts, but usually your systemic body oxygen consumption drops by 50% by by half for every 10 degrees that you go down. And the amount of ischemia that the brain can tolerate without flow also doubles with every drop in temperature. So I use these hallmarks that at temperature 37, the brain has only 2 minutes before it starts to sustain damage. At temperature 30, that time can go up between 6 and 8 minutes. Not that I advise that you circ arrest at temperature 30, but again, just to keep things in perspective. At temperature 28, the brain can tolerate up to 18 minutes. Now, once you go down to 18 and 16, then usually you have a safety margin of 40 to 45 minutes, maximum 16 minutes. But this is the most important thing. You need to make sure that you've cooled long enough before you introduce deep hypothermic circulatory arrest, because just cooling the patient doesn't mean that the brain is cold. The brain will take time, usually 20 to 30 minutes of continuous cold blood flow before the brain uniformly cools down. And just keep these in mind, that they lower the temperature. And also what your perfusion needs to be aware of, and you need to be aware of, that the lower temperature you go, you don't need to pump high oxygen in the pump. So you need to reduce the amount of oxygen that's pumped, because again, if you're giving 100% FiO2 inside the pump in the oxygenator, and the temperature, let's say, is 18, the venous blood is going to be red. And you don't need that much oxygen. And as again, oxygen is toxic. Oxygen is a drug. The more oxygen you give and it's not consumed, you're creating free radicals. In fact, this is one of my arguments of advocating for just isolated deep hypothermia, deep hypothermic circulatory arrest, as opposed to introducing deep hypothermic circulatory arrest plus augmented flow to the brain. And the reason is, if the brain is ischemic and there's no oxygen, that's fine. No free radicals are being created. Because this is what causes cell membrane damage, is that oxygen free radical molecules leak from the mitochondria and start attacking the cell membrane and causes the cell to swell. But if you just have deep hypothermic arrest, then there's no oxygen, and basically the cells are fine. Once you start, if the cells are ischemic and you give a little bit of flow just to keep the brain happy, then you're giving some source of oxygen-free radicals. In fact, some studies were conducted that showed that neurocognitive function in patients who just have deep hypothermic circulatory arrest is better than those who have hypothermic circulatory arrest with augmented blood flow. But if you anticipate the procedure to be complex, if you're doing total arch replacement with reimplantation of the neck vessels, and you expect that your procedure is going to last more than 45 minutes or 60 minutes, then by all means, you have to give augmented blood flow directly through the neck vessels, or retrograde flow through the SVC. But again, you just keep in mind, I'm a big advocate, and those who worked with me and I've done a lot of aortic surgery in my career and still love to do them. Just deep hypothermia alone is, in my books, adequate enough. Any questions regarding this issue?
I have a question about the dissection.
Yes.
The chirurgenic dissection. So in case of I drained already the patient, and they told me that art line is high pressure. So can I like cannulate the right atrium or so to infuse blood into the right side, since the patient is
yes, by all means. In fact, that's a good. I mean, this is more. You're not going to be asked about this in the exam, but what I usually do, and I think in my career so far, maybe this helped save 3 or 4 lives, is always keep the atrial cannulation site as your safety line. What I mean is, if you have a major catastrophe in the aorta, where your arterial cannulation site, you remove the cannula, the aorta ruptures. While cannulating, the aorta ruptures. Then what you do is you put your pump suckers in the pericardium to suck all the blood. Blood is going back to the pump, and then you introduce the arterial cannula into the right atrium. So what I usually do, see, when most surgeons, when they come off bypass, they take out, they give protamine, take out the venous cannula, ligate the atrium, and give the pump blood in the patient until all the volume is inside the patient and the ACT is normal. Or sorry, the protamine is half dose. But I always keep the purse string on the right atrium a standby. I will only tie the right atrium once I'm happy that the arterial cannula is out and that the aorta is hemostatic. Because if there's any catastrophe in the aorta, you put your finger, you put your suckers in, and take out the arterial cannula and just release the purse string on the right atrium and stick it inside the right atrium to give the patient their blood back and their volume. Otherwise, they're not going to have cardiac output. And just keep this in mind. Don't tie the right atrium once you take out the cannula. Just keep the snare on. tie it only once you're happy that the patient hemodynamically is stable and the arterial cannulation site is hemostatic. Faisal, did that answer your question?
Yes, thank you.
Okay, okay, good. Moving on to pump disasters. I mean, I don't think you're going to get these in the exam, but again, pump thrombosis or mechanical failure of the pump. Unfortunately, both of these has happened to me. What do you do? Let me give you a scenario that happened to me a few months back. You're on bypass. I'm doing a Bental. I put the cross clamp. All is fine, and then I give the cardioplegia, start dissecting the aortic root and the coronary buttons, and then the pump just decides to stop. What do you do?
So is it an electrical issue? They can use hand crack.
So, but what do you do as a surgeon? Forget about the perfusionist. Now you're the surgeon.
Well, at this point, I cannot wean the patient. So I ask for help.
Absolutely, guys. In every, whether it's pump, whether it's routine CABG, whether it's dissection, whether it's triple, quadruple transplant, you have a disaster, an issue. What do? The first thing is
ask for help.
Ask for help. Call a senior. Ask for help. Just yell, help, I need help. I will ask for help. So the first thing you do is is ask for help. Ask for everybody who's available to come and help in the operating room. Make that operating room a spectacle. So you just, but you do it calmly, obviously. You don't start yelling and screaming and shouting. Just ask for help. Call whoever the senior surgeon is. Call the head of anesthesia. Call the head of the department. Ask people, call all the perfusionists. Ask for everybody to be in that operating room. So that's the first thing you do. You keep calm. Again, I mean, you're not going to say this in the exam, but I mean, I'm just telling you that when you face these scenarios, which unfortunately you will face at some point in your career, just be calm. So your perfusionist now will go into, I mean, hopefully most of us will practice with very senior and experienced perfusionists. So you basically take over and just start pumping blood, because again, you cannot do open heart massage. The aorta is already separated from, the heart is separated from the rest of the circulation. And, but let's say if you have a cross clamp, you just take out the cross clamp and start doing open heart massage and ask your perfusionist just to keep this, the blood flowing by a hand crank. And then troubleshoot, whatever. I've had a situation where a technician from anesthesia decided to charge his iPhone and just unplugged the heart-lung machine from the socket. We only realized this after maybe 10 minutes of going into crisis mode. I've had a situation where the programming of the new heart-lung machine pump had an issue and there was a glitch and the pump just decided to stop. Sometimes you will have a thrombosis of the pump. In any case, what you do is call for help, ensure that call for help, put the head down, try to keep the systemic perfusion going either by a hand crank or by open heart massage. Pump all the volume to the patient, drop volume, drop blood, make sure that the patient is full so that there is some circulation. So when you do open heart massage, there is some blood circulating, or the perfusionist is basically just using his hand crank to keep the blood flowing. And then troubleshoot, whatever that is. From your side, you just want to make sure that there is blood flowing inside the patient and the head is down. And if you can cool the patient, fair and well. Cool the patient. Ask your anesthesiologist to put ice on the head while the head is down. Now, your perfusionist should troubleshoot. Should they change it to a new setup? Should they change to a accessory ruler head? Should they just bring a new heart-lung machine and set it up? That is their mandate, but you really have to work closely with them. Okay, maybe this is the last scenario. I mean, I can go on with pump disasters forever, but you're doing CABG. You just finish your your Lima to LAD graft, and you're happy with your graft, and you release the bulldog. And then you notice that the blood from the mammary that's coming out is really dark blue. And then you look at the arterial cannula, and the arterial cannula is dark blue. What do you think is happening here?
There's no oxygenation happening. So either so that could be the oxygenator itself has failed, or there's something with the oxygen supply.
Excellent. Most of the time it's the oxygen supply, because if there is thrombosis in the oxygenator, the perfusionist will notice that the pressure is high. But most of the time, and believe me, guys, this will happen throughout it happened during the Corona pandemic, people died. It happened to me so many times at different places where the oxygen system will fail for one reason or the other. So what you do is you, first of all, again, call for help, and keep calm and alert everybody. So basically, in every cardiac operating room, you should never operate without having oxygen cylinders standby, because this can happen on the anesthesia side, this can happen on the heart-lung side, but especially the heart-lung machine. If the main oxygen supply source fails, then you're going to rely on the oxygen cylinders. So make sure that the oxygen cylinders are readily available in the operating room and in the setup. And in such a scenario, you just basically hook up the oxygen cylinder instead of the main oxygen supply, and problem is fixed. I think that is for anybody has anything to add for pump disasters and pumps?
Doctor, in case an advert arterial cannula came off.
Oh, okay, yeah. So again, this is one of the things. I don't think you're going to be asked about this in the exam, but I mean, it happened to me. It happened to me when I was a resident, and I think it happened to me once when I was practicing. So basically, first of all, this should not happen. If it does happen, then that's a technical fault of the surgeon or whoever cannulated. Now, when you take your purse string, make sure you take, a partial thickness. The only thing that's going to hold your purse string is the adventitia, not the media. So make sure you have enough adventitia to hold your purse string. This is number one. Number two is the snare will not hold your cannula in place. The snaring, when you put your purse string, when you snare, that tightness is not what's going to hold your cannula. Your cannula can easily come out. What holds the cannula, and this is, I always alert my residents with me, what holds your cannula is the suture that you tie, the hand suture that you tie between the over the cannula with the purse string. So the purse string is like a rod. It doesn't hold the cannula down there. It will only hold the cannula if you tie it correctly to the cannula. So basically, make sure the most important ligature or tie you're going to do on cannulation is that one that holds the snares or the snuggers to the arterial cannula. If you are in doubt, do it again before you go on bypass. If you're in doubt, even add 1, 2 more. Clear?
Yes.
Okay. Cannula comes out. That's a disaster, because what do you think will happen when the cannula come out? Can you just easily put it back in?
No, you need to de-air the cannula, the arterial line.
طيب دي اصلا ما يحتاج، الكانيولا اصلا طرطشت في السقف في كل مكان ولطش يعني صبغت كل اللي موجودين في العمليات. ما عليك، الاير هذا ما حيكون فيها اير لانها اتس هاي فلو 5 liters per minute برا العمليات يطلع. What's the problem?
Losing the volume.
ايوه طيب volume. طيب you lose the volume. How can that what is the problem with that? I mean, other than shock and no blood volume, When you try to put the cannula back, how do you think the aorta will feel? It's flaccid.
Yeah. So
ما حتقدر تحصل. You cannot find the hole again. You're gonna be trying to put that cannula in, and believe me, it's like trying to thread a small needle. It's gonna be very tough. So you just keep your calm. In that situation, what I would do is I would put the arterial cannula inside the right atrium and start giving volume to the patient while doing open heart massage. Because again, I mean, if you can find that hole in the ascending aorta or in the arch, you put your cannula, you're lucky. Most of the time, believe me, it happened to me. I tried for like 2 minutes. The aorta is flaccid. You cannot find that hole, and the cannula will not go in. And if you force that cannula, you're going to cause aortic tear and injury and dissection. So maybe the safest thing is just basically just make sure you pump volume inside the patient. And the only way to do that, because the IV lines are not enough, the best way is just to take that arterial cannula with 5-liter flow and just stick it inside the right atrium and just infuse blood inside the patient while doing open heart massage. If the heart is beating, you're fine. If the heart is flaccid, just do open heart massage. Get as much volume inside the patient to distend that aorta, and then put your cannula back in place. Is that clear?
yes, clear.
Okay. Let's take a 2-minute break. I just need to make a phone call now. Our chairman is calling me, and then we'll discuss mitral. For the mitral now, I'm not sure, mitral is a big topic. But what I will discuss with you is the 2 main topics that come up in the exams is ischemic mitral and maximitous mitral, and also mitral valve exposure. I think these are the 3 things that usually we test the residents on, is how do you expose the mitral valve, and how do you deal with ischemic MR and maximitous MR. These are purely technical. I'm sure all of you have seen them and done part of them, if not all of them. And what I advise you is, the technique, the approach. You just really, really need to verbalize it. You need to let it flow. You just don't wait for the examiner to keep extracting questions from you, because believe me, most of them will just have a mask face and wait for you to spit out the answers. So when you're given a scenario about a mitral case, just automatically talk about how you take the consent, how you do the assessment, how you come up with the decision to operate, how you set up the operating theater, how you expose the mitral valve, and how you do the procedure. Most of the examiners will just stop you halfway. Once they see you flowing with the procedure and the steps of the procedure, they know you understand everything. So they're going to stop you, say, enough, let's move on to the next topic. But if you just, give a few answers and then stop and pause and wait for the examiner to extract questions from you, you're putting yourself in a deep black hole. Okay, 2 minutes, please, and then I'll get back to you.
Sure.
Assalamu alaikum. Whenever you guys are ready.
Dr. Rakan? Dr. Rakan?
Now,
do you mind if I ask you a very quick question regarding the previous issue where the dislodgement of the aortic cannula happened? Do you mean stopping the pump and infuse whatever volume you have in the pump through the aortic cannula, reversing the flow?
yes,
or?
yes. You don't. I mean, if the cannula is out, you have to stop the pump because otherwise you're going to splash all the blood, all the volume. You're going to flood the operating room with blood. But you stop the pump, and then what you do is you take out the venous cannula out and stick the arterial cannula inside the right atrium, because again, you want to pump volume. Now, the problem is most of the volume is in the heart-lung machine. You have 3 liters of blood, which is basically the whole volume, is in the heart-lung machine. And then there's no perfusion inside the body. So in putting back that cannula back, I mean, if you can put it immediately as soon as it come out, I mean, you're very lucky. Most of the time you won't, especially if all the volume is in the heart-lung machine. So what you do is basically you reinfuse that volume into the right atrium to fill up the patient, fill up the tank. And then if the heart is flaccid, you just do open heart massage until that aorta distends. Once that aorta distends, then it's going to be easy to put back the arterial cannula. Does that explain? Does that make it clear?
Yeah, that's much clearer.
Yeah, yes. So basically, remember that the arterial cannula is the biggest IV line you will ever have in the human body. And if the aorta ruptures, if the cannula comes out, there is no way for you to put that volume. But the safest way to put it back in is through the right atrium, because again, you're still inside the systemic circulation, be it through the venous side or through the arterial side. The only thing sitting between both is the heart. And if the heart is beating, you're fine. If the heart is not beating, that's fine. You can just fill up the heart with blood and then just do open heart massage. Don't underestimate what a open heart massage can achieve. And I'm not sure if you guys know, you don't do open heart massage like this. You're going to just rupture the ventricles. Happened to me many, many years ago. You don't want to do that. What you do is you put your left hand behind the heart and then with a fist on your right hand and just gently pump. And that can generate arterial, if the systemic circulation is full, that can generate blood pressure up to 100, 120 sometimes. Well, of course, with vasopressors that are given from the anesthesia side. So, I mean, the problem with us in cardiac surgery, we think of the heart in isolation from the systemic circulation. But if you think about it as just one continuous system and where just blood is flowing, then it makes a lot of sense. Okay, so, I mean, we're going to move on to the mitral. So, I mean, I'm not going to give you mitral cases, but I just want to, because again, I'm sure you're going to discuss a lot of these with your consultants and in preparation for your exam. But what I just want to summarize is just going to give you some tip points. So a very common question in any mitral case that you're faced with is, explain to me or give me the first 70 steps in exposing the mitral valve. The most important key steps in exposing the mitral valve. Can somebody just enumerate them for me?
Dr. Rakan, do you mean by the wave cannulation, things like that? Or what do you mean exactly by the question?
Just tell me how you expose the mitral valve. Again, remember, the reason why we ask about this is the mitral sits behind the heart. It's a very difficult area to tackle. So a key thing in mitral valve surgery is not doing a quadrangular or a triangular resection or a sliding plasty or resuspension. That's all easy if you have good exposure. If you don't have good exposure, then you cannot even do a simple mitral valve replacement. So getting adequate exposure of the mitral valve is key to performing effective and successful mitral surgery. So what are these factors? Start from the skin incision. I mean, just enumerate them.
So for the access, I can use median sternotomy or right thoracotomy as a minimally invasive.
Again, guys, for the sake of the exam, assume that all of your cases are going to be median sternotomy. I mean, it's unfair to ask anything regarding, any other approach, because again, at your level, I just want to make sure that you can do open heart surgery through a median sternotomy, which is, don't underestimate it. I know nowadays people are despising median sternotomy, and some surgeons might even consider it a crime to do median sternotomy. But believe it or not, it is very effective, reproducible. It saves hundreds and thousands of lives every day. So yes, median sternotomy, please.
So I would go with median sternotomy. Once I open the pericardium, I would suspend the right side and leave the left side down for further improvement to the exposure.
You already missed a step. Okay, Doctor, you already missed a step. This is going to be interactive. So where do you open the pericardium? Right side, left side, middle?
Usually you open it in the middle or towards the right a little bit. If we
towards the right a little, towards the right a little, because again, you want to suspend more on the right side than the left side. You want the left side to drop. You want the right side to be up. In fact, some surgeons I worked with, they will suspend the right side and then add deeper sutures to suspend more. So you want to really retract the right side and pull it up and let the left side drop so that you can twist the heart and allow the left atrium to come into view. Okay, so suspending the right side more than the left side, or suspending the right side and dropping the left side. Okay.
Yeah, and then I'd go ahead with the cannulation of the aortic and venous cannulation. For the venous, I would use the bicable cannulation in order to improve my exposure, even if I'm not using the transeptal access. Regarding the direct access to the mitral valve itself, I can do that through a right atriotomy and then transeptal approach, or transeptal extended to the dome of the left. Or
let me just come back to the bicaval. What is the advantage of bicaval cannulation in the mitral exposure? Can you do with double stage cannula?
Yeah, if I'm going through a left
atrium, you're going to go with left atrium, you can. Did you try it before, or have you seen anybody try it?
Actually, no.
Okay, I'll tell you, exposure is terrible. How does a bicaval cannulation make your exposure easier? Through the left atrium.
You don't have the cannula pressing on the view.
Okay, that's one thing. Another important.
And the drainage of the basically of the venous return.
Absolutely. So the problem is the right heart and the right atrium sits on top of the left atrium. If you don't have good drainage on the venous side, the right atrium will fill, the right ventricle will fill, and they're going to press on the left atrium. You're not going to see that left mitral valve very well. So when you have bicaval cannulation, that gives you full drainage. Plus, the other thing, you use the bicaval cannula to, like lifting up a grape stalk. When you lift up the bicaval cannulas and flip it to the left side, that allows the right atrium to come away from your view and you look directly at the mitral. Okay. Okay, so you said bicaval cannulation. Okay, what other things that can improve your exposure?
The left access of the left atrium is better than the transeptal approach. Sometimes it's the opposite, depends on the anatomy and the orientation of the heart itself.
Okay, so a transeptal approach, usually I reserve it. I mean, some surgeons do regular transeptal approaches, and that's fine. The problem with the transeptal approach is just takes a little bit longer. You increase the risk of having heart block and arrhythmias by going through the right atrium. But again, in difficult left side exposure, doing a transeptal exposure is very helpful, especially in ischemic MR, acute ischemic MR, where the left atrium is small and the exposure through the left atrium sometimes is almost impossible. You said, okay, go ahead. So you said you're going to do left atrium. For the left atrial exposure, what do you need to do to get adequate left atrial exposure?
Placing my stay suture on the edges of the
قبلها, you still have to open the left atrium. What do you do to facilitate your left atrial exposure? An important step.
Releasing the pericardial reflection. Releasing the pericardial reflection with the SBC and IVC.
Yes, dissecting, exactly. Well, usually that's a very adequate point. So basically, what I do is I release the pericardial reflection, the SVC, because that will give you more room to pull the right atrium away from the left atrium. If the SVC is fixed to the pericardium, then that's going to hinder how much you can. When you dissect, you don't need to dissect now, maybe a centimeter or a centimeter and a half. Just be careful, don't perforate the IVC. If you perforate the IVC, you're in deep trouble. For the IVC, you just need to open the oblique sinus. There is usually a film of pericardium separating the posterior rim of the IVC from the oblique sinus. So you just expose the oblique sinus. Okay, that's done. After that, the next important step is
develop the groove of Sondergaard.
Exactly. So develop the Sondergaard groove before I usually do it after going on. Some people do it before going on bypass. I think it's very dangerous, and the heart is not going to be, hemodynamics are not going to be stable when you put. But plus, I'm afraid if you breach when the heart is ejecting, if you breach the left atrium, then air is going to go. Air is going to be ejected in the systemic circulation. So what I do is after I go on bypass and the heart is fully deflated, I will dissect the SVC and develop the oblique sinus groove. And then I will develop the Sondergaard. The other name for Sondergaard is Waterston groove or posterior AV groove, whatever you choose. But the most common name we use is Sondergaard groove. And basically when you develop the Sondergaard groove, it gets you closer to the mitral. So the mitral is here and the groove, the AV groove is here. So when you develop the Sondergaard groove, you're going to edge more closer to the mitral valve. Plus, when you develop that groove very well, you can easily find the edges of your left atrium to approximate when you're doing the closure. Okay, so bicaval, opening the pericardium to the right side, suspending the right side, bicaval cannulation, releasing the pericardial reflection, developing the oblique sinus, developing the Sondergaard groove. Okay, what else? Yalla, keep flowing.
We will use a Cosgrove retractor.
Excellent. Okay, so a self-retaining retractor or a handheld retractor, but usually a Cosgrove retractor is going to give you a superior. How you place, some surgeons will ask you how your preference to place. Now I have my own system. Every surgeon has his or her own system of exposing the mitral valve. I'm not going to tell you what to use and what to not. Just make sure some surgeons might ask you, how do you put the retractor blades? Do you put them at which o'clock, 10 o'clock, 12 o'clock, 0 o'clock position? Just make sure that you know how to use the apparatus, at least in name. Just tell them where you position the retractor heads when on the left atrium. Okay, any other thing?
Stay suture as well. That can help.
Where stay suture? Where?
On the myocardium. I mean
myocardium.
Epicardium. Yeah.
So no.
And the left atrium. In the left atrium.
Where in the left atrium?
So the medial wall of the left atrium to your side, you want to tack that
exactly. You just need to use, I usually use a 4-0 suture. Just basically what happens is the anterolateral posteromedial part of the commissure. Usually there is a flap from the interatrial septum coming in your view. So when you put a stitch in the 4 o'clock position and pull it towards you, then that will bring the annulus closer. Any other trick to expose the mitral also?
Opening the left pleura if it is difficult to.
Okay, yeah, that's fair. I will take that. Okay, now let's say now you did all of what we said so far, and you're still. I mean, you can see the posterior rim of the mitral, but you cannot see the anterior annulus.
You can put the sponge in the heart.
Exactly. So a sponge on the right ventricle, and again, this will push the septum and will push the anterior annulus, so that it will push the interventricular septum and it will push the anterior mitral annulus into view. One thing I need to alert you guys, whether you're using a handheld retractor or a handheld retractor, it's called the Denton Cooley retractor, or the Kozgorov retractor, self-retaining retractor, it's always dynamic. It never works from the first setup. So you really need to sometimes I spend up to maybe 5-10 minutes. I know the pressure is on and everybody's on top of your head getting the mitral. Just take your time, adjust, readjust. And every time, if you're using more than 1, 2, 3 retraction heads, if you adjust one, then you have to adjust the others. So you keep playing with them, tweaking with them, adding a sponge until you get that not perfect, I wouldn't say perfect view, but near perfect view. Okay, so we've done all of this, and what is, you're not happy with the exposure. What will give you the best exposure? The step that gives you the best exposure?
Table adjustment.
Okay, it's not the best. Yeah, table adjustment, table away from you, so that again, it brings the mitral valve into view. Any other thing?
Place a vent like a sump sucker into the
vent is going to give you blood, but it's not going to give you exposure. Yes, it's going to give you visualization of through, because if you have blood, obviously. But any other thing? I don't expect you guys to know this, but I don't start operating on the mitral or do any assessment until I put the annuloplasty stitches, at least the ones from trigon to trigon. The annuloplasty are the most important step to bring out the mitral, because the mitral is still, even if you have good exposure, the mitral is deep. It's inside the left atrium, and if the ventricle is deep, it's going to be deep there. When you put your annuloplasty, in the beginning, it's going to be difficult. You're going to see the posterior annulus. Just take whatever you see with the posterior annulus with a 2-0 vicryl backhand and snap it. Backhand, snap it. And every time you take a bite, the mitral will reveal itself. It will deliver the mitral. There's an expression one of the Egyptian surgeons used to tell me. I forgot, but غرزة تجيب غرزة. Is that clear?
Yes.
Yeah.
Okay, so again, don't start operating on the mitral. Don't start doing any, especially if you're doing complex mitral repair or doing an assessment. You want to decide which areas prolapse, where are the cords, and just take your time. After you've done all the steps we described and you're still, the mitral is there, don't start immediately operating on the mitral. Put your annuloplasty stitches first. Even if you're going to do a replacement, that's fine. You can take the annuloplasty later, stitches later, but put your annuloplasty, and that will bring the mitral into full view. You don't need to put the annuloplasty on the anterior annulus. What you need to do is just on the posterior annulus, at least from trigon to trigon. I know surgeons who only will put 3 sutures, one in every trigon and one in the middle, in the posterior, in the middle of the posterior leaflet, and this will give you a beautiful exposure of the mitral valve. And then you can decide what you want to do. You can assess your mitral, decide to operate, patch, or whatever repair. Okay, with all of these discussed, let's say you did all of these. So what are your alternative? And I've had cases like this where you do all of these, still you cannot see the mitral. What do you
I
do?
can change to a transeptal approach. Maybe that will help.
Exactly. So
or
a transeptal approach. So what I usually do, I do a T incision. So basically, if I'm having bicaval cannulation, I usually don't, if I'm doing just left atrial approach, I don't put bicaval tapes. But if I have to now, I will put bicaval tapes and I will open the right atrium transversely, not longitudinally, transversely, and then open the septum transversely through the fossa ovale. Just remember, when you're opening the fossa ovale transversely, don't go all the way until the limbus, until the anterior limbus, because the limbus, there's just there's the left atrium is there. So you want to leave an edge between the anterior, a bit of rim in the fossa ovale between the anterior limbus and the floor of the fossa ovale, so that you can put a handheld retractor, a small retractor, a vein retractor, and just ask your assistant to pull, or put a pligated suture and pull. Now with that, most of the time you get the best mitral view, but I usually keep this procedure as a backup. In case I do everything through the left atrium and I'm still not able to see the mitral, then I will snare the Kyves and do a transverse incision through the free wall of the right atrium and the interatrial septum through the fossa ovale, and just keeping a small rim between on the anterior limbus, so that I can put a retractor there and expose the mitral. And just remember, once you put all of your annuloplasty stitches, it's a done deal. The mitral is done. The most if at least in replacing the mitral, the most important thing is putting the anchoring stitches or the annuloplasty stitches first, and that will bring the mitral in view. Any other approach that if this doesn't work, that you can do also to improve your exposure?
Maybe extending the incision to the dome of the left atrium.
Exactly. So it's called the Girardon incision. So basically, it's not extending your incision. So the left atrium, you can go. So if you open the left atrium, then you're limited to how far you can go on the dome. You cannot go very far, because again, unless you divide the SVC and divide the aorta, you're not going to see the dome. And by the way, the dome is very, very difficult to close. It's easy to cut through, but if you start having bleeding at the end of the case from that area, the patient is dead, because the dome is very thin tissue, especially in non-rheumatic mitral and endocarditis or ischemic mitral. The dome is very thin tissue. It's like paper thin, wet toilet paper. You don't want to play there. So I will leave the left atrial incision as is. Do bicaval cannulation, bicaval snares. Open the right atrium. This is the transverse one is called the depot incision. Now the Girardon incision is the one that is called the superior transeptal incision. And basically, you will open the right atrium in a longitudinal way or an oblique way, and then curve behind the SVC. Just shave off the SVC towards the surgeon, and then go through the dome. Now you will have the septum. You go through the fossa ovale again in the same manner and connect the dome incision with the transeptal incision. Is that approach clear?
Can you repeat it again, Dr. Rakan?
Unfortunately, I don't. Let me just see if I can sketch it here quickly for you guys. All right, let's see. Okay. Can you guys see this?
Yes, we can.
So the superior transeptal, basically what you do is you start your incision here. You don't start transverse longitudinal. You open your incision here. This is the SVC with the cannula going inside. So you curve your incision to go behind the SVC and then open the dome here. This is the dome. So once you're inside, there's the interatrial septum and there's a rim separating the interatrial septum from the dome. You connect both. So basically you are going through the right atrium behind the SVC to the dome and then opening the septum and then connecting the two incision, the interatrial septum with the dome incision. Is that clear?
That's clear, yeah.
Again, I've done it a few times in my career. It's not an incision that I prefer because, again, it's very extensive. Closing it takes forever. And I hate exposing anything in the dome because the dome of the left atrium is a very bad place to work with. If you get bleeding from there, then God help you. In textbooks, they will say if you are very, very, compelled, then you can divide the SVC and even divide the aorta to get access to the dome and a full exposure of the left atrium. I've heard about it. I've never seen anybody do it and never needed to do it. But I've used this Gerodon incision 3 or 4 times in my career. It really helped a lot. But most of the time, a left atrial approach, and if necessary, a key incision through the interatrial septum is adequate enough. I think, guys, this is, we're out of time now. It's almost 10 o'clock. But anybody has any questions more on the mitral valve? Because, again, this is beyond this, whether you do a quadrangular resection, a mitral valve replacement, an annuloplasty for ischemic MR, it's all easy. You guys have seen it, have done it. It's all, but the examiners will question you is the exposure, not the operative technique, and not the the technical operative technique on the mitral itself. Because once you have the mitral exposed, whatever you do, I mean, worst case scenario, you just replace the valve. Nobody will fault you. Replace the valve. That's fair and well. Any questions? Anything anybody wants to add?
راكان السلام عليكم.
هلا حبيب، هلا فهد.
كيف حالك؟ I just joined before you do the sketch. I joined. I just want to, ما شاء الله عليك, you're a very good sketch on the spot.
If you need any artwork, I'm always available.
يعطيك العافية.
الله يخليك، تشرفنا بيك دكتور فهد. Okay, the residents, anybody, people sitting for the exam, any last questions? Any?
Thank you very much, Dr. Rakan. It was really beneficial. We really appreciate your contribution.
أنا حاضر. أي واحد منكم يحتاج أي خدمة. I know some of you have asked me for a mock exam scenario. Unfortunately, for some reason, either they got busy or I got busy. But anyway, if anybody wants to communicate with me, by all means, I'm more than happy. الله يوفقكم وينفع فيكم، وعلى أمل أن نشتغل مع بعض بإذن الله في القريب العاجل بإذن الله.
إن شاء الله. شكرا جزيلا دكتور.
يعطيك العافية.
العفو، السلام. الله، شكرا دكتور فهد. السلام.
So I'd like to welcome Dr. Fahad Makhdoom, who's a consultant cardiac surgery at King Fahd University Hospital. And I'd like to thank you, Doctor, for organizing this review course. Thank you, Doctor.
الله يعطيكم العافية. السلام عليكم جميعا. تبغوا تاخذوا بريك 5 minutes ولا نكمل على طول؟
I think نكمل.
طيب، بسم الله الرحمن الرحيم. Let me just sharing. طيب معليش بس نتعرف مين اللي داخل اختبار السنة هذه لما نبدأ السلايد شيرنج.
فيصل الشمدين.
أيوه فيصل.
الهنوف العلولة.
عبد العزيز العتيبي.
وعبد العزيز. ونعم.
ومحمد
ثلاثة.
جلال.
4.
صحيح، 3 من الرياض و1 من جدة.
إن شاء الله، يلا بالتوفيق إن شاء الله. طيب شايفين السكرين الحين؟
Yes, we can see.
You can see my slide.
Yes.
طيب بسم الله الرحمن الرحيم. هنتكلم يعني نتكلم عن aortic valve surgery, aortic valve replacement surgery and transcatheter aortic valve replacement. The talk is going to be يعني mainly divided between these two topics. نتكلم عن guidelines, approach, pitfalls of the surgery, natural history of the disease, aortic stenosis. وبعدين هنتكلم on the other second half of about transcatheter aortic valve replacement, all the advances that happen and what do you need to know about it as a cardiac surgeon. First and foremost, طبعا we'll start with anatomy of the aortic root and the left ventricular outflow tract. As you all know, this is a very famous image of the anatomy of the aortic valve. You know, the aortic root is divided into 3 rings. The first ring is the basal ring, which is formed by the nadir of the 3 aortic cusps. And then we have the top ring is the sinutubular junction, and then the in between them you have a anatomical ventriculo-arterial junction. So where the ventricle end and the aortic and the aorta start, and between these, crossing these is the semilunar leaflet or the attachment of the leaflet on the aortic wall. Understanding this anatomy is very important in aortic valve surgery and in transcatheter aortic valve technology or procedure. And knowing all the important anatomical structure that is encased in this space is important to avoid all pitfalls of aortic root surgery and aortic valve surgery. So mainly the membranous septum, as you all know, is between the non-coronary and the right coronary cusp. So in the intertriangular leaflet, as you can see here, let me see if I can. شايفين my marker?
Yes, we can see it.
Yeah. So this is a triangle here. Usually, this area here was where the muscular ventricular crust ends. بعدين المembranous symptoms فوق. Usually the AV node is usually on top of the crust. As long as you're away from it, you're not risking causing any AV rhythm disturbances. The membranous symptoms is different in size or length between patient to another, and we gain this experience from obviously from previous open autopsies يعني, and from recent CT studies for transcatheter aortic valve technology. Other important structure that we have to know is the aortomitral continuity, and this is important in terms of when we need to know when you need to do any aortic root enlargement, or in case of aortic valve endocarditis or mitral valve endocarditis cases. Understanding the anatomy and the connection between the aortic valve and the mitral valve in this area is very important, because once you understand it, you can reconstruct it easily, hopefully. This is another image showing almost the same thing. On the lower part here, you have a 3D imagination of the anatomy. And again, so the mitral valve continuity, you have to know your trigon left and right, and where does it correspond on the left and non-coronary cusp. So you can, again, the importance of this here is in aortic endocarditis or endocarditis cases in general, and in aortic root enlargement procedure. Another variant of the aortic valve is the bicuspid aortic valve congenital anomaly, if we can name it. And it is very important for us to know all the variation of the bicuspid aortic valve. So we have 3 types, type 0, 1, and 2. And this depends on the number of raphes that we have. Type 0, which is rare, where there is no raphe. Type 1 is the commonest and has only 1 raphe. And mainly the fused leaflet will be the right and left fusion. So this is the most common phenotype of bicuspid aortic valve. And you can have other fusion between right and none, left and none, coronary, and then you can have the other rare type, which is type 2, where you have 2 raphes and 1 commissure. Can anyone of you tell me what is the difference between anatomical difference between a raphe and a commissure?
The raphe will be less developed, so it will be lower than the other commissures.
صح. هنا على slide, the commissure goes all the way to the sinotubular junction. So the sinotubular junction is a very distinctive ring on the aortic valve, on the aortic root. The raphe, as you mentioned, is less developed. So anatomically or on open surgery, you can see that it doesn't go all the way to the junction. And also on imaging, you can tell if it goes all the way, especially on CT scan, on cardiac CT. You can tell if it's a raphe or a commissure, because sometimes, and you will hear this term frequently from echocardiographer mainly, you'll have something that's called functional bicuspid aortic valve. So when you have a severe calcification of the aortic valve and fusion of the leaflet because of the calcification, the opening of the valve will be resembling a bicuspid opening. And the fusion here is mainly from calcium. But the distinctive feature between true bicuspid and functional bicuspid is that the raphe, whether the raphe is reaching up to the sinotubular junction or not. Okay, so aortic stenosis, what are the parameter of severity? The parameter of severity is depending on mainly on the hemodynamics of the valves, and this is nowadays mainly done by echocardiography, and as you know, in the past by in the hemodynamic lab or the cath lab. We're not going to go through the numbers. You have to know them by heart, and you have also to know the new staging on or it's not new anymore. The staging of aortic valve or valvular disease started in 2017 when the American Heart Association guideline came out. So stage A, B, C, and D, not very commonly used, but I think for purpose of the exam, you have to know the staging. The number that they use in the middle here, it's all the number that we are familiar with. But the only distinctive features or the difference are the symptomatic or asymptomatic. Just naming the stage I think will be important for you in the exam. So this is a famous diagram or graph that is about the natural history of aortic stenosis. I always use this diagram when I talk with my patients and when I'm discussing with them the aortic patient with aortic stenosis, discussing with them the nature of their disease and the prognosis of their disease, whether they have the surgery or not. As you know, once the symptoms start with patient with severe aortic stenosis, the mortality or the survival decrease dramatically, and it depends on whether he has heart failure, syncope, or angina. Heart failure being the most common, the most riskier one in terms of decreasing the survival. So anyone can tell me numbers or close number that we can use with the patient? Go ahead.
Yes, it's the survival is around 50% at 5 years for the angina, 3 years for the syncope, and 2 years for the heart failure.
معلش عيدي مرة ثانية for angina.
Angina is around 5 years.
5 years.
3 years for the syncope and 2 years for the heart failure.
طيب أنا المريض. Can you explain to me what does these numbers mean?
Yes. Like for example, you have congestive heart failure symptoms, aka orthopnea and shortness of breath, and pulmonary edema. So I would tell you that by you having the symptoms, your survival, your mortality is high at 2 years, basically. If we don't operate, if we operate, that significantly improves your survival.
What's the definition of high?
As in 50%.
50%, yeah. So 50% will have, 50%, if we have 100 patients, 50 of them with aortic stenosis and heart failure symptoms, in 2 years, 50 of them will be dead. And this is from earlier studies that gave us this graph about natural history of aortic stenosis. It's very important to explain to the patient this because you will when you're out in practice and you start seeing patient as an outpatient, you will see that some patient will have the episode of heart failure, and then they get admitted, for example, to the hospital, diagnosed with aortic stenosis that they didn't know about before. Get the treatment for heart failure with diuretics, beta blockers, and after load reduction treatment, and then they get well somehow, and then they leave the hospital. They come to you in the clinic, or you see them as an outpatient, and they will claim that they are okay now, right? So why would they need to go for open heart surgery or to have any intervention? So it is important for you to understand this natural history and be able to communicate it very well in the patient language. So what are the indications for aortic valve replacement in patient with aortic stenosis? And I'm sure you all came across or have ingested the recent guideline from American Heart Association and the European Society of Cardiology and European Association of Cardiothoracic Surgery. They are very similar, but I think you have to read both of them. This is a diagram that I took from the 2020 AHA guideline of valvular disease, and it has many details about the replacement of the aortic valve. It is mainly the same as the previous one in 2017. The only changes that we have here is the introduction of transcatheter aortic valve as a class 1 indication for severe AS and not only limited to intermediate or high risk patients. So anyone has question about the guideline or need more clarification, because I don't think we have to go through every detail in the indication here. So it is clear for everyone?
Yes, it's clear.
Okay. This is another diagram, and you can have this question in the exam, and either as in the written or in the oral part, as either they will tell you to list the class 1 indication or list all the indication of aortic valve replacement, or they will tell you in case if you have a case, and they'll tell you what class of indication does this patient have for aortic valve replacement, or whether he has an indication or he or she has an indication for aortic valve or not. This diagram, this table is about this choice of mechanical versus bioprosthetic aortic valve, bioprosthetic aortic valve prosthesis. So it's very simple. Mainly below 50 years of age, you recommend a mechanical aortic valve unless the patient has contraindication, or the patient will not be able to reliably continue anticoagulation treatment, especially in our country here. Between 50 to 65 years of age, you have a very extensive, you have to have very extensive discussion with the patient and explaining to them the pros and cons of biological versus mechanical valve, and the pros and cons of using warfarin as an anticoagulant on the long term versus not having warfarin on the long term. And then if you have a patient above 65 of age, bioprosthetic is usually preferred, especially with the advances in the biological treatment of the tissue currently. I think the numbers here has changed from the previous guideline was 70 and now it's 65. So you have low age of having bioprosthesis. The other thing that we have to keep in mind is that this has been introduced recently as well in the guideline, is the availability of Ross procedure for patients less than 50 years of age as an option for aortic valve replacement. This has to be done in, as mentioned, the guideline in a comprehensive valve center, where we have an experienced surgeon who has the experience to perform Ross procedure with a very minimal risk, operative risk, and very good long-term outcome. More literature has been available about Ross procedure and the advantage of survival in terms of mechanical or biological valve replacement in younger patients. Any question about the subject, choosing between which prosthesis we use? Okay, so this is, I think, it's a very interesting now hot topic again for the last 10 years, if I may say, since the introduction of transcatheter aortic valve technology, and the indication has been changing year after year. Sorry, the guideline has been changing year after year, since we have plenty of data supporting transcatheter aortic valve technology. As you know, and we'll talk about more details about the data in the subsequent slides, but the guideline has changed from 2000. In 2017, it changed from 2014, and in 2020, it changed from 2017, and it's all giving more space for transcatheter aortic valve implantation. The indication now is not limited to class 1 indication. Is not limited to only intermediate or high risk patient, but it also include low risk cohort. However, these low risk cohort patient has to have a thorough discussion, and there is other criteria that we have to consider before offering both options for the patient. Both of them was going to be class 1, but I will just draw your attention that for patients who are in the low risk group, if we may say between 65 to 80, SAVR or transfemoral TAVI is recommended after shared decision making about balance between expected patient longevity and valve durability. We have another slide here that we will come across, I think. This slide is again how to choose between or a guideline to choose for the heart team to choose between a surgical or transcatheter technology. But this is, I think, which is more important for you guys to comprehend all these factors that will favor either surgical aortic valve or transcatheter aortic valve. And this is where the heart team discussion becomes very important, and paying attention to the details and tailoring the treatment to the patient is of a mountain importance nowadays. So every patient is different, so we're not gonna lump them all. Either high risk goes for TAVI or low risk goes for surgical aortic valve replacement. That's why now working with our colleague from the intervention cardiology is of a great importance, and this importance will reflect on our results and hence to our patient. So we'll talk about this in a little bit more detail. So younger patient obviously will favor surgical aortic valve replacement, because up till now we don't have very robust data about the longevity or the durability of the transcatheter aortic valve durability. Older or fewer or shorter life expectancy will favor transaortic valve replacement. The valve anatomy, and this valve anatomy, we gather these information from the CT scan and from the echo. So for bicuspid valve, we favor surgical aortic valve replacement because we still don't have very robust, again, data about all the randomized trial actually have been excluding all bicuspid valve anatomy from both the self-expanding and the balloon expandable randomized trial. Patients who have significant subaortic calcification or left ventricle outflow calcification will be favoring SAVR, because, as you know, in the surgery we do good decalcification of the LVOT, and then you can achieve an optimal outcome in terms of paravalvular leak. However, in transcatheter aortic valve replacement, you don't do the decalcification. The presence of subaortic calcification in a patient will increase the risk of having a paravalvular leak. Rheumatic disease, small aortic annulus that need aortic root enlargement will favor surgical aortic valve replacement. Again, this is a topic that can be discussed in more detail. For a patient who has small aortic root, if you're just going to do valve replacement, open valve replacement without aortic root enlargement, you will achieve better hemodynamics with transcatheter aortic valve. But if you have patients with small root, younger patient who have less few comorbidity, let's say, and long life expectancy, then he's better being offered aortic root enlargement procedure with a surgical aortic valve replacement. So if obviously if the patient is preferring, or if the patient will have mechanical valve, then it's SAVR, not TAVI. Other consideration here, if patient had any other condition that require cardiac surgery, will favor Sabrent term more than TAVI. If patient has porcelain aorta or severely calcified, severe calcification of the ascending aorta, this is an indication to have TAVI to decrease the risk of preoperative stroke. Other non-cardiac condition that can cause morbidity of the surgery will also prefer to have transcatheter aortic valve. Frailty, which is a very big topic in this cohort of patient, and as you all know, the frailty that we in general, the cardiac surgeon has been assessing these patients by what we call an eyeball test, whether the patient will be fit for surgery or not. But nowadays there is a battery, plenty of batteries of measurement for frailty that can be used in a center to decide whether this patient is likely to benefit from any open heart surgery or not. So if the patient is frail, usually avoiding open heart surgery, pump, sternotomy, or even thoracotomy is better. And offering transfemoral TAVI will have tremendous benefit for them. So again, estimating the procedural risk, it comes back to all the factors that we mentioned above here. The anatomy we talked about here again, so it comes back to the same here: valve anatomy here, and here it's procedure specific anatomy. For example, annular size, low coronary osseal height. Will prefer to have surgical aortic valve replacement if the patient does not have good vascular access to allow transfemoral TAVI. Sometimes doing open aortic valve replacement, conventional aortic valve replacement, better than, for example, having a transapical TAVI. If patient, for example, here favoring TAVI, patient have previous cardiac surgery with a coronary graft that is patent, this is a point for transcatheter aortic, point to prefer transcatheter aortic valve replacement, or patient who received previous chest radiation for any type of malignancy in the past. There are plenty of data that showed adverse outcome with the open heart surgery in those cohort of patients. So again, just to summarize, there are many factors that an expert in the heart team has to go through to decide whether this patient is better to be served with surgical aortic valve replacement or TAVI. So, and this became available to us now after an extensive experience have been passed in this field, and as you can see, in the past it used to be whether the patient is fit for surgery or not. If he's not fit for surgery or high risk for surgery, then he goes for TAVI. Now it's changing. Now you tailor the procedure, you tailor the treatment to the patient, and sometimes you have a patient that comes for TAVI, but he's not fit for TAVI, then he goes for surgery. So the role has changed, and the importance, I think, of discussion and the heart team is more important now than in the past. Any question, comments? So we'll go to we'll switch now to aortic valve regurgitation, and we'll go through the indication of surgery in aortic valve regurgitation. The natural history of asymptomatic AI is, or the risk of asymptomatic AI in patient and those patients is usually developing LV dysfunction. and the mortality is very high for this patient. So that's why in the guideline of intervention, you will see that there is class 1 indication for asymptomatic AI once there is any evidence or signs of LV dysfunction, either it's dilatation or decrease in ejection fraction. Again, so the guideline is very important. This is this diagram is from 2020 AHA guideline. It is important for you to know it by heart, all the details. And then for aortic valve replacement, it's the same, either it's for whether it's for stenosis or for regurgitation. The pitfall, as we mentioned before, in your surgery is going to be always the membranous symptoms, or putting your suture in the membranous symptoms, and the aortomitral continuity. You have to know for your aortic root enlargement procedure. For people who's going to the exam, can any of you tell me what are the technique used to suture aortic valve prosthesis in conventional aortic valve replacement surgery?
One of the techniques is by using interrupted Teflon sutures, 2 O's, with either pledgets and small pledgets, either by placing them in the ventricular aspect of the annulus or the aortic aspect of the annulus, whether you want it to be intraannular or supraannular. This is one of the techniques.
Okay. What else?
There's a continuous technique. I haven't seen it, but I've read about it and heard about it, where basically I think you have 3 main sutures at the 3 commissures, and then you have like traction or looping stitches so that you can keep tension on it.
Yeah, so interrupted or continuous.
Yeah.
Those are the main technique that they're used for conventional just aortic valve replacement. And then you can also mention there are the root replacement is an aortic valve replacement technique. For example, patient, if you want to for patient who will have, for example, stentless valve, mainly the Medtronic freestyle valve. It comes in. It's a pig root that I don't know if you guys are familiar with it or have seen it, but it's a root, and it's mainly it's basically a bent valve that you will do to the patient. And it's one of the technique for aortic valve replacement. So if you get questions in the exam, this is considered also one of the technique. Okay, patient prosthesis mismatch. What is patient prosthesis mismatch? Basically, in layman term, if you put a valve that is small for the patient, right? So when is it moderate? When is it severe? Can anyone tell me how to calculate the patient, to define patient prosthesis mismatch in terms of numbers?
Yes, by dividing the affected orifice area over the patient's weight body surface area. And
Okay,
if you get a number of more than 0.8, this is an indication for patient prosthesis mismatch. If it's less than 0.6, that's a severe patient prosthesis mismatch.
Okay. So indexed effective orifice area. So your effective orifice area, where do you get it from?
The valve chart, the company valve.
Yes. So there are diagram or graph for for each from each company for the valve, and expected effective orifice area. This is done for before the patient, before it's implanted in patient. And then I'm sure you're familiar with those graphs where you have green, yellow, and red. Green, where you have no patient prosthesis mismatch, or the effective orifice, the index effective orifice area will be more than 8. And yellow, where you have in between, and then red when it's severe patient prosthesis mismatch. However, this number, the final number, you get it from echo. So you ask your echocardiographer to measure your effective orifice area for the patient, and then you index it to the body surface area, and then you will have your indexed aortic effective orifice area, and you can after that decide whether the patient has patient prosthesis mismatch or not. It is important to get these numbers immediately after you implant the valve, or once the patient is off pump, or the next day, because as you know, in biological valve there are degeneration. We will talk about prosthetic valve degeneration, and the effective orifice area will change, or the aortic valve area will change over time once the valve is used. So whether the patient has, if you have a patient who's for example 10 years post aortic valve replacement, and he has a gradient across the valve, and the echocardiographer will tell you the effective orifice area is now 0.7, for example, and you have only this information 10 years after the valve implanted. Can you tell whether this patient has patient prosthesis mismatch or not?
If he recently developed symptoms, most likely he didn't have patient prosthesis mismatch at the time of the implantation of the
if he has no symptoms
at that time, or currently
الحين بعد 10 سنين ما عنده symptoms. This is just a follow up.
What about the previous readings?
أيوة, that's my point. That's why I'm telling you it's very important to document for your patient, once you have the valve done, to document the gradient, the aortic valve area, and the effective orifice area index immediately post-op, or in the first once not immediately post-op, but as an inpatient before the patient is discharged. It's important documentation to compare all the readings that comes later on to these numbers. Okay. What if we have a patient with expected patient prosthesis mismatch for valve, i.e. patient with small aortic root? What are the options that you have to treat those patients? Can someone list me all the options?
We can do aortic root enlargement with whatever technique that we use.
طيب معلش انت أفنان صح؟ أفنان؟
هنوف.
سوري هنوف. خلي فيصل تتكلم.
Yes,
أو
sure.
جلال.
So we can use, if it is a small aortic root, we can use either supraannular position. This is one option. If it is like minimal, smallish root, we can use also some valve with good hemodynamic, like Regent valve, or mechanical. We can tilt the valve a little bit toward the non-coronary sinus. This is one of the mentioned. Other thing is to do enlargement, root enlargement, like or Manugian, or in very severe cases, Kono. And we can do like root replacement.
Great. There's only one thing that you didn't mention.
Sutureless valve. You can use
Sutureless valve. Yes, so sutural valve. So we have to aim to get a better effective orifice area by choosing the better prosthesis. And you mentioned that usually if we use mechanical valves, sometimes mechanical valve has better effective orifice area than biological valve, and also using externally mounted valve rather than internally mounted valve, placing the aortic prosthesis supraannular will give you a better effective orifice area. And then you mentioned aortic annular enlargement procedure, Manugian neck or Kono. And we're not going to go through the details, but you have to be able in the exam to at least describe those procedures. Aortic root replacement, i.e. Bental, is an option for these patients. Stentless aortic prosthesis.
And you can do aortic annular enlargement with pericardial patch.
طب هي نفسها aortic annular enlargement.
Aortic root enlargement with pericardial patch.
ايش what do you mean?
Because the aortic root you sometimes not need do aortic annular enlargement. All the aortic root add patch, pericardial patch for close.
يعني can you describe it يعني what do you do exactly?
I will open the transfer aorta.
أيوة.
During the closure, sometimes cannot bring the tissue. You can add the pericardial patch.
Yeah, but this is يعني أنت تتكلم على something else. You already implanted the valve, صح?
Yes.
On the annulus, صح?
Yes.
So you implanted you want to implant the valve, but the small root is not the annulus, but the sinotubular junction is small.
Yes.
صح? It's something different than what we're talking here. This is a technique that you're using to come across the difficulty of putting the valve across the sinotubular junction. صح?
Yes, doctor. This is common also.
Yeah, common in younger patients. But now we're talking about small root, i.e. small annulus, small annuli, and patient prosthesis mismatch problem. I think it's يعني somehow two distinctive entities.
And also
and then
about the EPCO aortic valve conduit.
It is an option, but يعني I don't think you should mention it in this question. Aortic LV to descending aortic conduit, and I have never seen it. It's only mentioned in the textbook, but I think it's very extreme. Nowadays we have better option, i.e. sutureless valve, TAVI, that can be done for patients with less morbidity than that epico-aortic conduit.
Thank you.
You're welcome. So sutureless valve is the last option. It has better hemodynamics, will result in better effective orifice area index, and it's the one of the options that you have to mention for small aortic root. Okay, so when you talk to a patient about choosing a biological valve, what kind of years or what would you explain to them, or what would you tell them about the longevity of the valve?
So for a bioprosthetic valve implanted at someone who's around 70 years old, then the durability of the valve should be up to 20 years in that age group with the current generation of bioprosthetic valves.
You know, the incidence, the incidence of structure valve deterioration at 15 or 20 years.
At 15 years, I think it should be less than 50%.
Oh, it's around 12 to 15%. So it's way less than 50. That's why it's considered, and this is from our surgical literature. And there are many let's say drawbacks for this statement, because the definition of structural valve deterioration from this literature comes from reoperation. So if you want to be more accurate with the patient, you'll tell him that you will not need surgery, inshallah. The percentage of patients who will need surgery at 15 or 20 years with a biological valve is only around 12 to 15% of those patients who receive biological valve. So because the structural valve degeneration now is defined as an acquired intrinsic bioprosthetic valve abnormality, deterioration of the leaflet or the supporting structure, resulting in thickening, calcification, tearing, or disruption of the prosthetic valve material, with eventual associated valve hemodynamic dysfunction manifested as stenosis or regurgitation. And looking for structural valve degeneration has not been actively used in the previous literature for surgical bioprosthesis. So the structural valve degeneration was defined as a requirement of re-intervention or redo surgery for a failing valve, because you can have a patient with structural valve degeneration who has severe parameter, i.e. a gradient mean gradient more than 40, or significant intravalvular regurgitation, who is asymptomatic, and for those patients usually there is no intervention will be provided, since it is since the patient is hemodynamically or is asymptomatic. So this definition is new, and grading of structural valve degeneration is becoming more available now, and you will see it probably in the near future in the literature. This is a staging that has been proposed from a group of researchers to standardize the definition of structural valve degeneration for surgical and transcatheter prosthesis. So stage 0, 1, 2, and 3, and all the details in between. So for these special cases, what type of prosthesis you will use? Hemodialysis patient. What do you think? If patient is a 50-year-old who is on hemodialysis for chronic renal failure with aortic stenosis, would you offer him mechanical or biological valve?
biological valve.
ليش؟
avoid the heparin complication warfarin complication.
Any other opinion?
With the hemodialysis patients, there's controversy. Classically, they say that the renal failure accelerates valve degeneration in tissue valves, but at the same time, their life expectancy of hemodialysis patients is shorter. So probably tissue valve is a better option for them. In addition, if they're a candidate for transplant, then you decrease the complications related to anticoagulation with dialysis and transplant.
Yeah. So I think I agree with all of you. It is controversial. You have to have a discussion with the patient cardiologist, and with the you have to know the prognosis of this patient, whether he's going to have transplant or not, and so forth. So there are special cohort of patients that have no straightforward answer, to be honest, but you have to put all of these factors in consideration. Pregnant lady or a lady in a childbearing age who require aortic valve replacement.
By prosthesis or ROS, if it's done in an experience center.
What's the problem of a mechanical valve?
So it's the issue of anticoagulation and teratogenicity of warfarin.
So can they take warfarin or not?
So better to avoid warfarin in the at least first trimester. It is associated with teratogenicity, especially if the warfarin dose is more than 5 milligram. So it's better to use the alternative for the first trimester than warfarin before before 1 week before the planned delivery, then switch again to heparin.
Good. So patient who's living in a remote area, or non-compliant patient, or a drug addict, or patient who have a very high risk of bleeding, for example, patient who had GI AV malformations or GI, some inherited disorders in the gastrointestinal tract. All these patients have some contraindication or difficulties in using oral anticoagulant. So you have to have, whether they are, even if they are young in age, you have to have extensive discussion and weighing the pros and cons of using warfarin or not, or also putting yourself in a place where you're operating on a stuck valve and the stuck mechanical valve, and the risk of operating on a stuck mechanical valve compared to operating on a failing bioprosthetic valve in those patients. This is a graph where it's a transition slide I put that shows us the development of artificial valve prosthesis since the 1960s until 2020, where we started to have 2002, where we started to have the sutureless valve and the transcatheter valve. It takes us to the second part, or the last part of the procedure of the presentation, which is we'll talk in a little bit more details, technical details about transcatheter aortic valve implantation. For sake of the exams and for sakes of or for your career, nowadays it's becoming a common knowledge. You have to know all the literature or the trials that came for comparing transcatheter aortic valve to surgical aortic valve prosthesis or procedures. As you all know, you have partner 1, 2, and 3 for low risk, intermediate, and high risk. And you have the core valve US pivotal trial, then you have CERTAVI, and then you have the low risk trial for the partner was for the balloon expandable valve, and the other one was for the self-expandable valve. The NOTION trial is also an important trial that was one of the earliest trials that included also low-risk patient, and it was a mix between balloon expandable and self-expandable valve. So you're all familiar with the trial, صح?
Yes.
You should know it, and you should really know, read it, understand it, know the numbers. It is important for your exam and for your discussion with your patient and colleague in cardiology and interventional cardiology in the future. So those are some of the available prosthesis that for transcatheter prosthesis that is CE mark. Mainly for you guys, you have to know that there is self-expandable valve, balloon expandable valve, which is Edwards Sapien. And I think now we're up to generation of Sapien 3. We had Sapien XT, then Sapien 3, and now Sapien 3 Ultra, I think. And then the self-expandable valve, the most commonly used is the Medtronic Evolut. And again, Medtronic, we have the Medtronic core valve, then Medtronic Evolut, and then you have the Evolut R, Evolut Pro. This valve is not available anymore. The Accurate Neo is also is a Boston from Boston Scientific, and it's a self-expandable valve that is also available here in Saudi Arabia. Portico is a self-expandable valve that is from St. Jude, very similar to the Medtronic valves available in Saudi. And then there are many other companies, to be honest, that became more available now and CE mark approved. But for you guys, the main difference that you have to know, the main two type you have to know is balloon expandable valve and self-expandable valve. Okay, I put this slide. This slide is a little bit old, but you have here just for you to know a category that used to exist, now not anymore, I think. Mechanical expanded valve is something called a valve was called the Lotus valve. That is, I think, doesn't exist anymore because it has many mechanical pitfalls in terms of technical implantation. So it was withdrawn from the market. It might become available sometimes in the future, but I'm not sure. Again, so for you, you have to know balloon expandable, self-expandable, because all the trial is based on these two valves here. What are the limitations for transcatheter aortic valve implantation? Historically, the limitation that we have from the trials, based on the trials, right? When the first the technology was introduced, paravalvular regurgitation was the main limitation or adverse outcome comparing these technology to surgical aortic valve. And then you have conduction disturbance, neurological complication, vascular complication, and the durability. We'll go on them in a little bit more detail. So paravalvular regurgitation, as you know, because we're implanting the valve without decalcification, without definitive fixation of the valve of the prosthesis to the native aortic valve annulus, so you have risk of paravalvular regurg. In the earlier in the experience, and these numbers are all from the literature from your trial, the incidence of more than moderate to severe paravalvular regurgitation was ranging from 9 to 12, and then in the second generation of valves and second generation of trials, it has decreased to around 3 to 4%, and now in the latest generation of valves, you can see that the valves has an added skirt here, also in the Evolut line. The incidence of paravalvular regurgitation has decreased to 0 to 1.4. This is the incidence of moderate to severe paravalvular regurgitation, and you know that more than moderate or more paravalvular regurgitation was associated with a long-term mortality for those patients. That's why it is very important. Now, why did it decrease? Not only because of the technology has changed, or the technology of the valve, but also the experience has changed in the field. So introduction of CT scan measurement was a significant factor that decreased the paravalvular regurgitation. It has led to more understanding, more accurate sizing for these valves, and that therefore decrease the incidence of paravalvular regurgitation. As you remember from the slide where we compared the surgical aortic valve to transcatheter aortic valve, where we're going through the anatomical feature or the factors, whether it's anatomical or non-anatomical, to favor whether this patient has a surgical or transcatheter valve. Many of these anatomical features we know it from CT scan or preoperative CT scan. This is another slide showing that the incidence of paravalvular moderate or severe paravalvular regurgitation has decreased with time. So again, it's all from the trial. This is from the first trial in the high risk patient, and then you have another Evolut R study that you can see that the incidence of regurg has decreased, and then the latest this is only a observational trial, when the observational study for the pro version of the valve, only 58 patients, but there is some indication that the regurgitation has decreased or disappeared. The other limitation is heart block. Heart block, as we know, and we talked about earlier, we have the membrane symptoms where we have the conduction zone, and it's mainly the AV node, as I mentioned to you before, is on. If we have a cross section here of this segment here, you will see that the membranous symptoms is this, and then the crust or the muscular part starting. So this is the perimembranous symptoms, and as we mentioned before, it has a different length, and then the muscular symptoms start down here. The AV node is on top of the muscular symptoms. So as long as you avoid taking your stitches deep here, you can avoid conduction disturbance. With transcatheter valve, you have to be as high as possible. Usually our landmark is the basal ring. So the line that's connecting all three nadir. So you need to measure your depth of implant, and because the membrane symptom is not fixed or not fixed among all patients or all human, the risk of heart block in transcatheter valve is more common in transcatheter valve rather than surgical valve. This has unfortunately did not change a lot, since even with the advanced technology and with our understanding of this technology, you can see here it was ranging from 3 to 20%, 8 to 25%, and then 10 to 11% in the latest trials. It is more with self-expandable valve rather than balloon expandable, and this is attributed to the continuous radial force that the self-expandable valve exerts on the aortic root. The incidence of paravalvular leaks, of heart block has increased with the introduction of the skirt on the SAPIEN valve, and this is understandable because you have more material that is interacting with the aortic root. Neurological complications. So at the beginning of the literature or experience, surgeons were very skeptical about this technology. We were very skeptical, as you know, because just the concept of putting all this big catheter across the aorta, and we all, as a surgeon, we know how is the aorta in patient with severe aortic stenosis has significant calcification, sometimes plaque here and there. The aortic valve itself is full of calcification, so there's no careful decalcification. As you can imagine, there's so many debris that will fly to the brain. So at that time, yes, the neurological complications were higher. However, understanding, becoming the technology, avoiding certain patients who will have adverse neurological outcome, and then also the decrease in size of this catheter that's delivering the valve had led to decreased neurological. And in the latest trial, the neurological complication was actually less in the transcatheter cohort rather compared to the surgical patient. Vascular complication, although it's still common, but it has decreased. And the main reason for that is that with the advance in technology, you have smaller size sheath, and the requirement for big femorals has become less and less. Nowadays, you can implant these safely through a transfemoral access in a patient who have 5 to 5.5 millimeter iliofemoral vessel. Other alternative access that is transapical, transaortic, subclavian, carotid, innominate artery, and transcaval. All of these vessels have been used to deliver a transcatheter valve. All of them has some pros and cons. The transapical approach has become less favorable now, since the data showed that those patients, they don't do as well as the transfemoral, actually, and sometimes an open surgery might be better. The durability of the valve, until now, I think in the literature, we have some data up to 5 years only. And these data are limited and not very robust, because as you know, the initial literature or cohort of patients were very elderly patients. The mean age of the first partner one was around 80 to 85. So the life expectancy is low. So if you go through the literature of partner and you read the 5 years report, you will see that there's the available number starting from 700. At 5 years, the numbers were around 200 to actually measure to actually judge the durability. That's why the durability is still a question that needs to be answered. So from these past few slides, I think we can answer that paravalvular regurgitation. We can choose, we came to understand how to avoid paravalvular regurgitation, or how to mitigate the risk of paravalvular regurgitation, neurological complication, and vascular complication. Heart block and durability is still questions that need to be answered, and it's still an important limitation that has to be discussed with the patient among the heart team when choosing between transcatheter or surgical aortic valve. And this was the last slide. I thank you so much. I think we have exceeded the time. If you have, we'll do 5 minutes for question if you have, or discussion, and then so you guys can move on. I'm sorry we started 5 minutes late, so we took 10 more minutes. Any questions? So I hope the slides were clear. The talk was not very boring.
Actually, it was clear. Thank you very much, Dr. Brad.
Okay, so and I will leave you for the next presenter. Thank you so much, and inshallah bitawfiq for everyone. If you have any question or any request, you can always contact me. I think my email is available for all of you. If not, Haytham has my contact. بالتوفيق جميعا. السلام عليكم.
Thank you for taking the lead to organize this course.
بالتوفيق، حياك الله.
Dr. Shabir.
Yes, Assalamu alaikum.
Salam wa rahmatullah. I would like to welcome Dr. Shabir Shah, who's a consultant cardiac surgery in King Fahad Medical City. We will talk about post-MI complication. So if you're ready, Dr. Shabir, and you want to share your slides, and would like to thank you for the contribution. Thank you.
Yeah, allow me to share the screen. Huh?
Yes, I think now you can.
Okay. You can hear me?
Yes, Doctor, we can hear you and we can see the slides.
Okay, great. Okay. Shall we start?
Yes, please, if you're ready.
Okay. So I'll be presenting this topic. It is mechanical complications of acute myocardial infarction. So basically, you know, these are the only case reports or some case series. There is no robust evidence or the guidelines for this topic. So the level of evidence is just personal communication or a level C. And you guys might see these cases in your lifetime, maybe one or two cases or few cases, or maybe not even, because now the technology and patient care is improving. So the number of cases are going down day by day. So basically, in the mechanical complication of acute myocardial infarction, we divide them into the three groups, like rupture of the left ventricular free wall and rupture of interventricular septum. So pathophysiology of both of them is the same. And then is the third one is papillary muscle rupture or necrosis. And in another case, all these complications lead eventually to the 3/4 of the patients into cardiogenic shock. And the cardiogenic shock has even his own morbidity and mortality. And the fourth one is basically the chronic complication, which is pseudoaneurysm formation. So clinical characteristics of these mechanical complications are, say, like papillary muscle rupture. The patient goes in pulmonary edema, cardiogenic shock, and there is severe MR, and you will see the mobile mass and the prolapsing into the LA. The commonest complication, which is a ventricular septal defect. Excuse me, just hello. مدير بكرة يوريكم وش أور تاني. So the second one is ventricular septal rupture. It could be, you know, asymptomatic to the circulatory collapse. There will be the shunt and high continuous wave Doppler velocity on echo. The pseudoaneurysm, it is another complication. Actually, it's a chronic complication, which is actually when there is a rupture, pre-wall rupture, and is contained, and it leads to pseudoaneurysm formation. So what is the incidence and prognosis of these mechanical complications in the current era? This is a latest literature in circulation 2001. If you can see the incidence, this is from the multiple reports, and the incidence in the perfusion error was around 1.7. It is still constant, though it has come down, but not that much extent. But still, we see the good number, like 0.27% overall, as has been reported in 2015. The mortality was very high in reperfusion era, but recently it has come down, but still around 40 to 50% of the cases die out of these complications. This is a very interesting article. I suggest all of you, you should go through this article, which shows overall trends and outcomes of mechanical complications in patients with acute myocardial infarction. This was in JACC 2019. This article reported almost around 1 million cases with STEMI common, around 4 million, and non-STEMI, which was around more than 5 million. The complications of mechanical complication in STEMI were around 0.27%, and less complication was seen in non-STEMI, 0.06%. So mechanical complications are commonly seen with STEMI rather than the non-STEMI. In STEMI, the commonest complication you will see is ventricular septal defect or ventricular septal rupture, followed by the papillary muscle rupture, and then is the least common is the free wall rupture. Similarly, also in the non-STEMI, the commonest is the VSR, and then followed by the papillary muscle or free wall is almost the same. If you'll see what is the trend from last more than a decade, from 2003 2015 in the STEMI, if you'll see the trend, there is hardly any decrease in the mechanical complications, even though the technology has improved. We can see there was around like 0.27, still it is the same, it may be 0.3 here. And when we subclassify the mechanical complications into papillary muscle rupture or VS or LV rupture, there is still there's no significant decrease from the last 1 decade. And when we go through the mortality also, there is hardly any improvement in the 2000, more than a decade from 2003 to 2015, which is around like 40% of these patients usually die. Similarly, in the non-STEMI, there is no change over the last decade. And even in the mortality, there is no incidence change and no change in the mortality. If you guys have any questions at any time, you can stop me. If the things are not clear and you have any doubt, please ask me the question. Okay?
Okay.
Yeah. So the most important factor which has been seen in this paper was age. So if you have an elderly people, they usually have the highest mortality compared to the younger patients, and female have been seen, they have a higher mortality compared to the male. The gender difference was seen only in the STEMI, not in the non-STEMI. So when we say comparative outcomes among patients with STEMI myocardial infarction who had a mechanical complication versus no complication, these patients are usually have high mortality. They are more in cardiogenic shock. I guess they are more than 50% or even higher acute kidney injury. They go in acute kidney injury and have hemodialysis, respiratory complications, and most of them, nowadays, circulatory support is put on the more than 50% of the patients. Similarly, non-STEMI. So there is no difference in the STEMI and non-STEMI in case of the, compared to the patients who have no mechanical complications. So both types of MI, whether it is STEMI or whether it is non-STEMI, and have an associated mechanical complication, they have the more problems compared to those patients who have no mechanical complications, and even though they have a high comorbidity and in shock. We'll bypass this slide. So current era shows the ventricular rupture, the incidence is 0.2% in STEMI and 0.04% in non-STEMI. Similarly, papillary muscle rupture it is 0.05 in STEMI, 0.01 in non-STEMI. Fever rupture is 0.01, 0.01 in both STEMI and non-STEMI. So the summary of this paper is the mechanical complications in STEMI is 0.27%. In non-STEMI, it is 0.06%. No significant change over time from 2003 to 2015. In hospital, mortality is around more than 40% STEMI and 18% in non-STEMI. No changes over time more than a decade. Patients with mechanical complication have higher rates of in-hospital mortality, cardiogenic shock, acute kidney injury, hemodialysis, respiratory complications. We use quite often the mechanical circulatory support in these patients, and they stay longer in the hospital. In hospital, mortality is higher in particularly elderly patients in both and non-STEMI patients. However, in hospital, mortality is higher in women in the STEMI, but not in the non-STEMI. Use of mechanical mechanical circulatory support in this patient is around 50%, which was present in this paper, which we are describing now, and it was around 25% in the non-STEMI group. Let us go one by one. We'll go with the post-myocardial infarction ventricular septal rupture, which is, as we have seen, is the commonest complication post-MI, as per the literature. As I said before, these are just a case series and case reports, and we'll be presenting our case, and then we'll go step by step what we did with this patient and what happened to this patient during our presentation. So this was a 57-year male. He presented with acute anterior septal STEMI 18 hours after his MI. Large anterior septal VSR was diagnosed. He was in shock state. He was intubated, ventilatory support was put in, and he was started on vasopressor inotropic support, and anuria on, he was anuria furosemide infusion. And of course, we put IABP usually is started in this patient. So just remember this case, what we'll go during our presentation, we'll come back to the case back. So what is by definition a VSR? A post-infarction ventricular septal defect is an opening in the ventricular septum resulting from the rupture of acutely infarcted myocardium. So we presented the first paper, which we're discussing in 0.2 and 0.04. There are other evidences, and we show the incidence, like GRACE registry 0.26%, Apex acute MI trial, which shows 0.17%, Gusto trial shows 0.2%, New Jersey myocardial infarction data, it shows 0.27%. However, in the shock trial, it was very high, because in this, most of the patients, most of them were in shock state. So whenever a patient has a shock, you have to rule out acute mechanical complication unless proved otherwise. I think the historical background is not that important now, so we'll bypass this slide. So what happens to the VSR if you do not operate them? So nearly 25% of the patients will be dead within 24 hours, 50% in 1 week, 5% in 2 weeks, 80% in 4 weeks. So, and 1 year, only 5 to 20% survive. So this is a real emergency and salvage procedure, which of course needs expert, the surgeon and the expert team, including the ICU. Spontaneous closure of the post-infarction ventricular septum has been seen, but it is very those who have a very tiny and they come late, and usually they disappear with time. So this slide is from the curriculum, and you can, the same thing, they usually die early during first 2 weeks. Most of them die in 80% or 70% die in first few days, first couple of weeks. Then they survive over 1 year around 5 to 10, 20%. When do you diagnose? So identification of VSR has been seen now in these trials, has been diagnosed within 24 hours in shock trial, Gusto trial, and in an MX acute myocardial infarction trial. But in the pre-thrombolysis, usually we diagnose 3 to 5 days to establish a diagnosis of VSR. What is commonly, when we ask a question, when we diagnose, they say 2 to 5 days. in the first week. But nowadays, the acute MI, because of the availability and advancement, we usually diagnose them in the first day whenever they present the hospital. As I said, any patient in cardiogenic shock, you have to rule out mechanical complication unless proved otherwise. But sometimes we may see, late presentation, say the patient presents in the couple of weeks, even, in a month time, the patient present is late, he comes with heart failure and then it is diagnosed with the echo is a chronic like VSR or a rupture papillary muscle or a pseudoaneurysm. You will see the cases which while we're presenting, we'll see in the different timing of presentation of these cases. This is the same case. I was in the case report, we put a summary of the case. This is the echo of that patient. You can see there is a large VSR, and then there is, you can see the serpentine course whole septum was infarcted. So pathophysiologically, we classify them into the simple rupture where there's a direct communication between the left and the right ventricle. And while the complex rupture, where we see there is a serpentinous course and more likely to be caused by the irregular tears within the necrotic septum, as seen in this slide with this photograph. There has been another classification, what we call it is a Becker and von Madigan classification, which is true for pre-wall rupture. Since the pathophysiology of the ventricular septal rupture or pre-wall is same, so this classification is sometimes included in the VSR as well. So what happens in the type 1, as we said, is a simple rupture where there's abrupt tear in the wall without the thinning and is a through and through hole. And in type 2, there is infarcted myocardium, erodes but rupture occurs and is covered by the thrombus. So these patients are usually relatively stable. They are sick, but they're stable. The third one is a marked thinning of the myocardium, secondary formation of an aneurysm and perforation in the central portion aneurysm. So there are contained ruptures and they present with the pseudoaneurysm. They can come with like chest pain or heart failure symptoms. So what leads to this rupture? Every myocardial infarction patient does not have these mechanical complications. So it is like a single vessel disease. They are more prone for the rupture. Extensive myocardial damage, bigger the MI, the bigger chances of the mechanical complication, particularly the STEMI, have more common than the non-STEMI. Where there is poor septal collateral circulation, and LAD and right coronary arteries are almost they're equally involved in these complications. Anterior and inferior infarctions contribute roughly equally to the VSR. These following conditions are not usually the risk factor. If the patient has hypertension, diabetes, prior smoking, prior MI, these patients are less prone to develop the mechanical complication. They may come in a sick state or a shock state, but small, unlikely they have the mechanical complication. It is possible, the reason is it is possible that these patients have pre-existing coronary artery disease, which leads to the development of protective collateral circulation. But it is equally possible that these patients develop cardiogenic shock or fatal rupture, and there may be observational bias. How the VSR patient is present? There may be a dyspnea at exertion, or they may be severely sick because of the cardiogenic shock, or even they may be asymptomatic if you have a tiny VSR. A new cardiac murmur is nearly always present. The new murmur is typically harsh, loud, and hollow systolic. It is best heard at the lower left sternal, usually the right sternal borders, and occasionally you can see all over the chest. And right and left ventricular, you can have the S3 gallop, which is very common. P2 may be loud. You have to differentiate between the mitral regurgitation murmur. Sometimes it is very difficult to differentiate. And third is severe mitral regurgitation may occur in 20% of patients who develop the VSR. So both conditions, there may be two mechanical complications in one patient. So eventually patient develops, develops a cardiogenic shock. Most of them, say like 3/4 of the patients. And you guys know what is the left heart failure and the right heart failure, and the sharing of these symptoms. So after clinical, how we diagnose you? X-ray chest is not a diagnostic usually. ECG may show the ST changes or elevation or whatever the MI is there. I think the most important diagnostic tool is an echocardiography, which is usually transthoracic. And to complete the echocardiographic examination, I think most of the patients will require TEE. And the pulmonary artery catheter, nowadays it is very uncommon, but sometimes you may need a pulmonary artery catheter. Of course, coronary angiography is important tool, not to diagnose, to rule out the associated coronary artery disease in other vessels, and a possibility where there sometimes we do CABG with the VSR repair. The patient is very stable, and you may ask for a CT or MRI as well, but unlikely. So most of the time we take the patient diagnosis with echo and then coronary angiography. So chest echography and ECG are not much diagnostic. However, what we see in the echo, it is an accurate information in terms of location and size of the septal defect. It is associated with ventricular wall motion abnormalities, can be exactly defined. Mitral and tricuspid regurgitation can be also quantified if they are associated with VSR. Assessment of left ventricular, right ventricular size and contractility. So the most important diagnostic tool is an echocardiography. This is the same patient that we are discussing, and this is a hole in this is a short axis view. We can see the ventricular, and then we can see here is dropout, and we can see here in the shunt cross going into from left to the right. So you can see this echocardiography where we can see the shunt is from the left to the right. It was a large ventricular septal defect. The same in a different view. And this is then we will take a long axis. We can see the serpentine course. The septum is dissected with the acute MI. This is another patient. It's not the same patient, where we can see this is the ventricular septal rupture, and then we can see the shunt. It is hugging through the wall of the RV. This patient, if you concentrate here, RV looks fine because there is no much shunt, but the LV is severely dilated and has a severe decrease in ejection fraction. It was around, I guess, 15 to 20%. He presented late, and he had an associated aneurysm. The aneurysm, it was a pseudoaneurysm associated with the VSR. Alhamdulillah, we operated him, and he did very well. Sometimes we may do a Swan-Ganz catheter, which it may be introduced on bedside. It reveals the step of oxygenation saturation in the RV, and we can calculate how much is the shunt. It also helps us in wedge pressure calculation, and that reflects basically the left atrial and LV endosteric pressures. Pulmonary artery pressure usually elevated, but we rarely do this. But this is done particularly in the post-operative period. Those who have a low outputs, cardiac output, it is helpful to treat this patient in ICU. Coronary angiography is important thing in the diagnosis, as well as particularly they rule out the coronary artery disease in other arteries. In case of severe coronary arteries, additional coronary angiography grafting for surgical closure of chest should be performed. On occasion, in the catheterization laboratory, the ventriculography may help to confirm the presence of VSR. And so VSR may be associated with multivessel coronary artery disease or the ventricular septal rupture. There is a high prevalence of a single vessel disease. Around 50% of patients may have only a single vessel disease. And ventricular septal rupture is likely to be associated with total occlusion of the infarct-related artery. So that is why it is more common in STEMI rather than the non-STEMI. So you will see you may have a single vessel disease, the total vessel is cut off, and sometimes around 50% you may have multi-vessel disease. So how do you manage them? First, we start with they are in the critical area. So we start with medical management. Then you might need a mechanical circulatory support to stabilize perioperatively. And then you have to plan your surgical repair. And sometimes those who are not a surgical candidates or prohibitive, or some patients may be candidates for the percutaneous device closure. So timing of surgery, when do we operate them? This is a controversial issue. There has been no guideline is clear what to do. Although the surgical mortality remains very high, non-surgical mortality is certainly higher. Thus, the clinician must weigh the known risk of surgery against the unknown risk of postponing the surgery and developing further clinical deterioration. So this is very controversial issue, the timing of the surgery. In AHA guidelines in 2004, patients with STEMI complicated by development of VSR should be considered for urgent cardiac surgical repair unless further support is considered futile because of the patient's wishes or contraindications or unsuitability for further invasive care. CABG should be undertaken at the same time as a repair of the VSR. This was class 1 indication in 2004. So do not delay them. Then in 2013, there was a little bit change. Emergency surgical repair is necessary even in hemodynamically stable patients because of rupture site can expand abruptly, resulting in sudden hemodynamic collapse in previously stable patients. So as per the AHA guidelines, we should take the patient as early as possible before he goes into multi-organ failure. However, in the European Society 2017, their recommendation is early surgery should be performed in all patients with severe heart failure that does not respond rapidly to aggressive therapy. And the delayed elective surgery may be considered in patients who respond well to aggressive heart failure therapy. So basically, if the patient is stable and he is lactate and he is holding and is making urine and his liver kidneys are stable, and he is not on high support, the better is to delay the surgery of these cases. Is a general guideline. If the patient is on inotropic support, vasopressor support, he is on borderline, you think he is going to deteriorating, it is better to take them for surgery before they develop a multi-organ failure. Because one is the established multi-organ failure, whether you put the mechanical circulatory support and then operate, the outcome is very dismal. So 30-day operative mortality for VSR with immediate surgical management or at various times of points of delaying. So if you immediate surgery, it is the risk of STS data shows the 60% the patient has died. But if you do percutaneous, even 88%. So taking them early period is definitely a high mortality. But the problem is, if you delay this surgery, they may not survive. So if you operate in 1 to 7 days, the surgical mortality comes down and STS like 50%. If you further delay the surgery, like in 2nd or 3rd week, it is 30%. Delaying even more than 3 weeks, even the mortality as per STS data is 10%. But if you keep on waiting these patients, but no attempt at surgery or percutaneous, 94% of the patients will die by 30 days. So again, so stable patient, which will come in a few slides, you will come to know that stable patient is better to wait. Unstable patient is go take them to the surgery, even you have a high mortality. Because if you keep on waiting, they will eventually die and have multi-organ failure and eventually die without any intervention. So if you have an acute MI with VSR, if hemodynamic unstable, it is better to take them to this immediate surgery. Or you can put some mechanical circulatory support in the form of ECMO and IABP, and then decide how they are behaving, stabilize, and then decide. If it's hemodynamic unstable and you don't have an ECMO, or they are not the candidates for mechanical circulatory support, and they are not the candidates for surgery, and if the anatomy allows and your percutaneous closure has been done, but this is just as I said, the evidence is just on the case reports. If you are hemodynamically stable with large VSR, then consider close monitoring after reduction, IABP, ECMO, and delay the surgery as much as possible. But hemodynamically stable with small VSR, just delay as much and take them in, in an elective fashion. Or if it is very tiny, the shunt is very limited, nothing to be done. Or they may be a candidate for the percutaneous device closure. This slide, this is the treatment pathway for stable, unstable, any mechanical complication, which include the VSR as well as the other complications. You have signs and symptoms suggestive of mechanical complication, immediate cardiac imaging to confirm the diagnosis. The most important here being the echo, then transfer to the specialized centers who manage the sick patients, then divide them into hemodynamically unstable and stable patients. And then in nowadays, there is a multidisciplinary team usually. It could be a shock team or a heart team usually, which takes, you should discuss them in the multidisciplinary heart team. Then plan, it could be, depends on the patient condition. Patient can go either cardiac surgery, medical management, mechanical circulatory support, and delay surgery, percutaneous repair. Even the LVAD, if he is not a candidate, or a palliative care, just leave him alone, and just only the medical management. What are the surgical techniques? Usually, broadly, we classify these into the two techniques. One is has been described by the Daggett technique, which is a single or a double patch technique, which close the VSR by placing a patch over the defect after infarctectomy. Yani we trim the VSR, then we put a double or a single patch, and it is stitched to both the LV and RV. The David technique, which is most common, which I use, is an infarct exclusion technique. We put all the sutures in the healthy myocardium and they hold better. And results are much better in the infarct exclusion technique compared to the infarct technique, which was previously described by the Daggett et al. So the first one is infarctectomy, which has been, which is not commonly used nowadays. We trim and then we put a patch, usually a pericardial patch, is bovine pericardial patch. We use the pledget sutures. We cross them from the left side and then go to the right side and place another pledget. So the pledgets are both on the ventricular side of the septum and on the right ventricular side as well. And closure of the septal without tension, you should put a loose. Buttressing of the suture line is with pledgets and Teflon to prevent the suture from cutting through. But usually, this is very difficult to stitch this when you have an acute infarction. Usually they cut through. It really needs an expert surgeon. So infarct principles of exclusion repair of post-infarction, VSR. This is what I do, and which should be done is we don't touch the infarcted area. Then pericardial patch is sutured with a continuous proline around the defect to exclude it from the LV cavity. And then full thickness bites are taken into the epicardial surface and anchored by strips of pericardium or Teflon. Another patch is then, anterior patch is then anchored to the non-infarcted septum below the defect, then the non-infarcted anterolateral ventricular wall. Okay, let me go to the images. So how I do it? So put a patient cardiopulmonary bypass, bicaval cannulation. Then I just put them on moderate hypothermia. I give always in these sick patients blood cardioplegia, a cold one. ventriculotomy through the right superior, the vent is put through the right superior pulmonary vein, and distal coronary anastomosis are performed before we go to repair the VSR. So left ventriculotomy incision is then, this is an anterior infarction. So I'm just put only one, not the posterior one. So we put, we do an ventriculotomy parallel to the LAD, 1 to 2 centimeter away the LAD. Anyways, we don't repair here LAD because this whole area is infarcted. So the stitches will come through the LAD area. So you don't worry about the LAD artery. But if you have a like circumflex disease and RCA disease, it's better to put a graft before you fix this VSR. So ventriculotomy is done. Then stage sutures are applied through the margins of ventriculotomy to aid in the exposure. Then you can see here in this image, you can see a big hole in the septum, and then the patch is stitched to the healthy myocardium. You can see the, that it is in the base of the septum way down, and then we bring this patch then anterolaterally. So this is the right ventricle, this is the LAD area, and this is the patch which we have sutured in the base of the septum, and then I exteriorize these stitches on the anterolateral wall of the ventricle. So we have a right ventricle, we have left ventricle, and in between will be a small, residual cavity. This is the final how we close the ventriculotomy. It is by the 2 layers with 2 strips of Teflon felt using the Prolene. You can use a 3-0 polypropylene suture or 2-0. I usually use a 2-0 polypropylene suture on the big needle. This was the case I was describing before, and you can see this how this patch looks. So this is the right ventricle, this is the left ventricle, and this is the patch very loose. You should not be under tension, otherwise it will dehiscence will happen. So there was no shunt across this patch, and the patient did well. This is one of the case reports I did. We did an infarction. He had a lower septal atrial defect with an which was congenital ASD, and he presented with an acute VSR. And I think this is the this is another patient. You can see there is a large ventricular aneurysm, and then we opened it. There was a he presented actually in a subacute condition, and then he was taken to the cath lab. They tried to fix the VSR percutaneous, but they could not pass the virus. So I took him to the OR. We excised the aneurysm. Then if you can see the forceps are going through the tract, there was no through and through hole. There was a tract through the septum. That is why they could not pass the virus. Then we repaired it through our infarct exclusion technique. And this you can see the final, very ugly, but this patient did well. Actually, post-operative course in this patient is very difficult. It is a multidisciplinary team and involving the many people, cardiologist, intensivist, respiratory therapist, nutrition. Everyone plays his part in managing this patient. Show this small video. This is the same patient. What we did it, I think so. Can see the acute MI, it's a hemorrhagic MI. The heart was slightly adherent to the pericardium. Then we incised it. We did an anterolateral, just 1-2 centimeter away from the LAD. We did a ventriculotomy, and then we put 2 retraction sutures. This helps us in exposing the VSR. You can see the VSR is exposed now. You can see in the middle there is a big hole. The forceps is going through the hole. Then we put a patch in the base of the septum, and then anteriorly we bring this this patch and stitch it to the from the septum to the anterolateral wall of the ventricle, and we don't touch the septum at all because it's all necrotic. This is the stitches outside the ventricle on the anterolateral wall of the ventricle. This is final how we close with pledged sutures and then cover with some Surgicel usually, and then patient was off the bypass, did well in post-operative period. So review of literature, as I said, this is one of the important papers by Tyrone David in I think long back. He did around, this was 44 patients, and most of them were in cardiogenic shock, and he just had I think out of 44, 6 patients died, and he had a 5 years, 6 years survival was around 66%. This is one of the best papers I come across, excellent results. I think the same then in POC exclusion technique, sometimes what we put 3 patches. We put here is a 1 patch, it goes into the right sided, and then we put another patch connecting to this one. So double patch technique. And then we come anteriorly and fix it to the ventricular musculosa. This is one of the shock trial, in this, there were out of 939, 55 patients were had a VSR, very dismal prognosis. Out of 55, only 31 were operated. And out of those, there was 6 survivors out of 31 who were operated, 19% survival. And 24 which were not operated, only 1 survivor. So very bad prognosis if you do not operate. I think we'll buy, okay, this paper, if you see in this here, so operation done in early within 24 hours has a very high mortality. So this paper also shows that waiting is better if you can. It is not a law, but if you can wait, patient is stable, better to wait and a few days or a week or so and then take to the OR. This is also important paper. This shows an STS data. This is in Annals of Thoracic Surgery 2012. In this around nearly 3,000 cases have been in STS data in adult surgery, around 3,000 cases, and operative mortality was around 54%. If the repair was done within 7 days, but it was just 18% if repair was done more than 7 days. So in the STS data, if you see around a decade, this is the number of procedures. They were constant. This is the first half of 2010. The number of cases were constant during this decade. And even the operative mortality did not improve from 1990 up to the 2010. The percentage of mortality is around 40% or even more. This is from the STS data. This also from the STS data, Society of Thoracic Surgeons. Again, it shows again the operation done early has a high mortality compared to late. So more evidence now accumulating to delay this surgery unless patient is demanding early surgery. The risk factors for mortality, particularly as I said, elderly, female gender, those in shock. If you have an inferior infarction, it is technically demanding and usually they are more sicker. That is why they have high mortality. Pro-operative, those who are on balloon actually is a risk factor. Basically, they are sick patients. Those who are in renal failure, associated mitral insufficiency, had a previous cardiac surgery. Those who go for emergency have a high mortality. So timing of repair is important. This is a triple patch technique. As I said, there are case reports, so this is not something standard. So every surgeon tries his technique and modifies as per his need. So they put one patch with the infarct area, then another patch with the non-infarct area. So this is actually combination of both techniques, and then put a glue in between. This important paper, from the Brazil, it shows 55 patients. They operated 40 patients, 19 survived and 21 died. So more than 50% mortality. So elective cases were 5, all survived. Basically, they are very straightforward, and you delay their surgery. So none of them died. And if you do not operate them, they just die. Okay. So sometimes, after surgical, there may be a recurrence of the septal defect. As I said, it's difficult to stitch the infarcted area. So there may be a 10 to 25% of patients as they develop the recurrence. Large, what should we do with them? If they have a large defect, then it is better to repair them. Small defects which are not important to have a small shunt, they can be managed medically, or they can go later on to the percutaneous closure and surgical closure of late post-operative residual defect has been reported. There have been some report where they do a right atrial approach, but I have never done any right atrial approach. So who are the candidates for the percutaneous closure? Most authors suggest that defect should be small, less than 1.5 centimeter, and inferior and posterior defects are challenging because of they frequently lack the adequate tissue. So usually done in the anterior VSRs. If you have a serpentinous defect, then they are difficult to percutaneous closure. If you have a fresh infarct myocardium, so necrosis is ongoing, making device leakage or even device mobilization a concern in these patients. There has been a percutaneous device closure, some case reports with varying success rate. So what is the home take message is that the post-myocardial ventricular septal rupture is a rare and potentially fatal complication. Surgical correction carries highest mortality among all surgical procedures. Clinical presentation predicts the outcome. Treatment strategy should be individualized according to the patient's clinical status and hemodynamics. Successful surgical outcome depends on the prompt recognition. So this was the VSR. You have any questions on the VSR?
Thank you, Dr. Shabir. I have one question regarding to the remaining.
Hello?
So in terms of remaining, yes, can you hear me, Dr. Shabir?
Yeah, go ahead.
Yeah, in terms of the remaining cavity that's left in the RV, is there any problem with that? Did they develop thrombus or something? Because I saw the other technique you show in the paper that they put glue inside it. So would you advocate that? Or?
Yeah, so what I do is I do an infarct exclusion. I put the sutures in the base of the septum with Prolene and use this one pericardial patch. I bring this patch out. I put sutures from the patch to the anterolateral wall of the LV. What we see in this video and this slides. So now we have small cavity. We have now two septums. One is pericardial septum, which we reconstructed, and we have the natural septum, which has a perforation, and then is an RV. So there is additional small cavity, which is on the RV side. Okay. So usually we put them on aspirin only, and then this it heals gradually because this is healing occurs. So I have not seen any thrombus or anything in this cavity, and as per the literature I have gone through, there has been no evidence of any thrombus in this small cavity. Usually it stacks up and heals. There is no issue with the small cavity. It's a very small cavity basically. And thrombus, if your LV is, is severe LV dysfunction, say ejection fraction 15%, akinetic, or small pseudoaneurysm or something, thrombus can happen there, yes. Particularly the LV side, which are very risky.
Oh, okay, thank you.
Any other question on VSR? Because then we'll have some slides on the papillary muscle rupture, and then we have pseudoaneurysm, and then we have pre-wall rupture. Shall I go to the next presentation, or you have some questions on the VSR?
Hi, Dr. Shabir. Just one question. As a general rule, if you have a patient with a VSR and they're not adequately resuscitated with ICU management and inotropes and so on, do you think it's better in general to put them on ECMO and keep them for at least 2-3 days before thinking about taking them to the OR?
Absolutely. So say if you have a young guy, he's 40 years and he's cardiogenic shock, and he is a very fresh case, and you did an echo, you diagnosed it as VSR, right? So now you put a balloon. What I do is I just put a balloon straight away. So you just put an IBP balloon and start him on some support, and do his ABG and his baseline and see how his urine is making or not making. Usually, if it is a fresh and he has all organs are good, I just take them to the OR. And keep an ECMO backup. I inform them because you may have difficulty in weaning off from the bypass. So I did like 5-6 cases. So any patient who was, most of the patient, I think 7-8 cases I did. The patient who were not stable, they were hemodynamically compromised, but had making urine and where the lactate was not still high, they did good. I did last 2 cases, to be honest with you, they were very sick, lactate was high. I took them, there was no backup, no ECMO. I thought anyway, they are dying. So they were inferior MI and both of them died. So my general principle is if the patient is sick and he is not in multi-organ failure, take him to the OR with a mechanical circulatory support backup. Of course, IABP is there, but maybe you may need an ECMO as well. If the patient is like, he came with late and he has an advanced shock, advanced shock, lactate is high, he's on high support, his kidney, his INR, his liver is gone and INR, I will not take him to the surgery. So what I suggest in these patients, have a heart team discussion, and probably I will advise to, if he is young patient, and after discussing with the family, we can go to put him on the mechanical circulatory support, which includes many things. If like a 75% has an advanced disease, is multi-organ failure, I think, and this is a heart team decision, involve the family, and probably, I will be very hesitant to put even a mechanical circulatory support, or maybe just, palliative care only. So each patient you have to individualize. So you have to have a case scenario, and depends on the case scenario, you take your decision. There is no definitive guidelines. But suppose a patient is stable and he start deteriorating. So don't wait. Then if he was stable, he start deteriorating now, you go and take him to the OR. Don't wait till you have an advanced shock and advanced, things have gone beyond control. Yes.
Okay. Yes. Thank you.
Have anyone has seen any VSR or any other mechanical complications appear done as assisted or observed?
I was in one case last year. We had a free wall rupture. Actually, the only ones I've seen are free wall rupture straightly. One as a junior and one last year as a senior.
Oh, so what happened to that patient? Because
the first one was in the cath lab actually, and they called us and we rushed up. We put her on pump femoral cannulation. At the same time, the cardiologist had put pericardiocentesis line just to relieve the tamponade a little bit. And after we placed her on femoral bypass, we opened the chest and we managed to control the bleeding. But she came out on ECMO, and I think she took around 10 days on ECMO after the repair. We did. It was also like a infarct exclusion, or basically, so we patched the whole area where the myocardium had ruptured with like Teflon strips to support the patch, and she survived, alhamdulillah.
Oh, great. Is a almost similar story I will present here in the free wall rupture now. Do we have the time or?
Yes, doctor, we have.
Okay, so whenever you tell me, I can stop, But anytime, just stop, and because this is a learning lecture, this is not something, just presenting it. So I think you guys did a good job in that case in a ventricular. This is almost a similar story here. We had a 69-year-old male. He had an anterolateral MI, late presentation. PCI was done to the LAD. Post PCI became hypotensive, was resuscitated, IABP, inotropes, vasopressor, as a usual story. LV angiogram showed an LV rupture. Echo was done, cardiac tamponade, pericardiocentesis done in cath lab as your case was done. We shifted him to the OR for salvage, and we did a linear closure of the free wall rupture. So this is how they, you can see there is a cardiac tamponade. There's lots of blood. The patient was almost collapsing, and we did an angiogram which was showing the rupture. Then we did a linear closure as you can see in this view. So the left ventricular free wall rupture is a life-threatening mechanical complication, which current incidence, as we have seen the previous paper, is around 0.01. And left ventricular free wall rupture is relatively common in autopsy. These patients usually just die. They don't reach to the OR or the diagnosis. So sudden death, they just suddenly die. PVR rupture should be suspected in any patient with hemodynamic instability or collapse after acute MI, especially in the setting of delayed or ineffective reperfusion therapy. What is they usually relatively who are stable? You can see them venous distension, jugular venous distension. This is pulsus paradoxus. You can see electromechanical dissociation, muffled heart sounds if the patient is still conscious, and ECG may show an acute MI changes. We'll bypass this one. So I think we presented this paper in detail. So the commonest etiology of free wall rupture is acute myocardial infarction. Other cases you have seen blunt or penetrating trauma, cardiac surgery. Sometimes you did a mitral valve, and then you can see that there is a rupture of the LV, and cardiac tumors can rupture. I have not seen anyone, but I have seen a blunt trauma. I have seen a rupture from the MVR, and I have not seen any cardiac tumor or any infection which giving to the rupture of the myocardial rupture. So pathophysiology is same, I don't think we should discuss it more. We can have an acute ventricular free wall rupture. It is just, we call it blow type of rupture. Then is a subacute type, rupture. It is just oozing and then, sealed off. And the third one is like, it's a chronic ventricular free wall rupture, which present usually with a pseudoaneurysm. This classification I presented before, type 1, where it's an acute tear. Type 2, whether there is, so acute type is acute tear, usually blow over. They usually die before you take them to the OR. And type 2 is like, they are eroding and they may be relatively stable. And type 3 is just as a pseudoaneurysm. As I said in the clinical presentation, I think it is the same. The diagnosis is usually made by presence of, echocardiography is important diagnostic tool. And you can show a content, maybe hematoma, or there may be a pseudoaneurysm. Sometimes pericardiocentesis may help, but I don't suggest a pericardiocentesis for the diagnosis. And contrast ventriculography, if the patient is already in the table and cath lab, otherwise no need. But you may, if the patient is stable, you may take him to the angiography, but otherwise not for the diagnostic point of view. If the patient is stable, particularly who have a type 3rd, what we call a pseudoaneurysm, you may do a CT and MRI in these patients. Sometimes, patient as is collapsing, and there is just the cardiologist says there is a hematoma on the epicardium. You just take them to the OR and before they die. So these are the guidelines. What we say is a STEMI adequate use of mechanical circulatory support, such as IABP, ECMO in all post-acute myocardial infarction complications for temporary circulatory stabilization. So most of them, it is an IABP, not the ECMO. So almost every patient is on IABP. So what we do is, as well, we do a linear closure. We can do infarctotomy, then close with a patch. And there have been recently, if there may be sutureless technique. So different materials have been used to patch it. The most common is a Teflon or a Dacron or pericardium patch. We just put it. Then we use a taco seal when we stitch it. Sometimes taco seal. I use very quite often this taco seal. And bioglue, yes, it can be used. But with these bone wax, cyanoacrylate, monomers kind of bone wax, I have no experience with this. So I use a bioglue, I use taco seal, I use a patch and stitch. So this is just a diagram which shows how to do a linear closure, how to put a patch and just cover another patch. This is just adding a bioglue or a taco seal only. This this image shows a taco seal. If you have a chronic and you just, there is no oozing and much, you can just put a taco seal and leave it alone without any stitches. There has been some case reported, but the recurrence of the rupture is high in these cases. So personally, what I do is I do most of the time linear closure. I take a big bitus without any fear and then cover with a taco seal. This is the same case. And so these patients also have a high mortality, as we have seen in the VSR. They have been reported like 17 to 43, 35% have been mortality, depending on what article you have read. And increase in percutaneous now mechanical circulatory cases. People are putting them in circulatory support, but to be honest, it has not shown any improvement in survival. Basically, they are on case reports, so difficult to judge. This is a different review of literature where the different series have been presented, and the mortality overall, as I said, ranges up to the 35% of the patients. So what is the commonest site? Usually the anterior wall is 6%. In this paper, it was in 17%. So commonest was lateral and inferior wall, and posterior wall was the second commonest. So pre-war rupture is it is a devastating complication, and with delayed or no reperfusion, usually is a sudden cardiac death. High clinical suspicion from diagnosis confirmed by echocardiography. Immediate surgery. ECMO may be needed in the perioperative period, and primary patch repair that covers the defect when feasible. A sutureless repair using a patch or a glue or a collagen sponge can be used in small sutures as an adjunct to therapy. So this was a pre-war rupture. Any question on pre-war rupture? No questions on pre-war rupture. Okay, let us go through the. This is papillary muscle rupture. Anyone has seen assisted or helper papillary muscle rupture? You can hear me?
Yes. As a junior, we had one case. I think he was a young guy, around 40 or 42 years old. He had acute MR with a papillary muscle rupture after an MI. But we did a mitral valve replacement for him. But he did well, alhamdulillah.
Excellent. So we have a similarly one case, a very interesting case, because these are only case reports, you know, there is no guidelines, there is no definite what to do. So it is a case scenario, individualized and tailored approach should be done in these cases. So we have one patient who was a 64 years male patient. He was admitted with non-STEMI. He was stable and he was in the floor. So echo was done. We showed a moderate to severe MR, moderate LV dilatation, and severe LV dysfunction ejection fraction. What happened next day? So this is his echo before rupture. He was in the floor and he was stable. You can see RV is good, LV is dilated and has a severe LV dysfunction. And there was a moderate MR, as we can see in this echo picture. There was a moderate eccentric jet. So what happened next day? His condition suddenly deteriorated. He became pulmonary edema followed by cardiogenic shock. He was transported to CCU. He was intubated, inotropic vasopressor support, IABP in cath lab. He almost arrested, you know, it was a pre-arrest and a brief CPR, but he was stabilized. And he went to CCU, and then we could diagnose he had a papillary muscle rupture, severe MR, LV dysfunction was already there, and now he also was having a posterior inferior late aneurysm. You can see the same patient. You can see now that he has a muscle is ruptured, and it is a prolapse of the posterior mitral leaflet going into the LA, and he has a torrential MR. So what we did in this photograph, you can see, in forceps, we can see the papillary muscle, and this was all torn. And we did his, it was a complete muscle rupture. We did an MVR with 29 cm tissue value, and through spiriton septal approach, it was an uneventful postoperative course. But we didn't touch his, pseudoaneurysm posterior. It was inferior-basal. So he is on follow-up more than 1 year. He is doing fine. He is an NHF function class 2, and he showed a large pseudoaneurysm in the post-operative period. But it is difficult. He is doing well. I'm not sure at some stage I might have to go back and fix his pseudoaneurysm. I think the incidence of papillary muscle rupture is very, very small, right? 0.01 to 0.05, and you can have a complete rupture. You can have incomplete rupture, and you can have partial rupture. So it depends on the what is the anatomy, because the papillary muscle is not fixed. If you have observed in the OR, they usually have the varied anatomy. So every patient is different. So this is very important management point of view. A rupture of the papillary muscle morphology. 2/3 of the patients have partial or incomplete rupture. 1/3 of the patients are incomplete rupture. In the posterior middle papillary muscle rupture is 75% of the cases because of the single blood supply from the PDA. Anterolateral papillary muscle is less common because of dual supply from the LAD and circumflex. MI may be large or small, it doesn't matter. Infarct may be subendocardial or transmural, so you don't have to have an always STEMI. And it may be associated with other mechanical complications like VSR or a fever rupture. Clinical feature diagnosed within few hours, it may be delayed up to 2 weeks. And these patients may have pulmonary edema, hypotension, cardiogenic shock, heart failure. With partial rupture, they may have less MR. There is usually a murmur, but it's not as common as we see in VSR. And there may be a third heart sound because of the heart failure. So chest radiography may show pulmonary congestion and enlargement. Swan-Ganz catheter, as I said, is very uncommon now, but it may need in some cases to see the associated other mechanical like shunting, or you can see diagnose VSR, or even the the prominent wave which you seen in the MR. I think the most important diagnostic tool is echocardiography. You can mitral leaflets are failed, prolapsing, rupture portion can be directly visualized, and differentiation of papillary muscle rupture and LV dysfunction from the other problems. You should exclude the like VSR or a severe LV dysfunction only. The same case, what happens them, and then 25% of patients is treated non-surgically, surviving more than 24 hours. Partial rupture, they have better prognosis. More than 70% of the patients survive the first 24 hours and 50% in 1 month. Technique, distal anastomosis or bypass is performed before we go to the mitral valve. The approach to the mitral valve is through the left atrium or superior transseptal approach. I always do the mitral valve through superior transseptal approach. So total papillary muscle rupture, it is better to do the MVR. It is mechanical or the biological depending on the indication. General guideline, just follow those. Partial papillary muscle rupture and caudal mechanism is, if it is intact, you can just mitral valve repair can be done. Because of the rarity of this condition, only few surgical series have been reported. Mortality ranges from around 20%, even higher, depending upon the patient profile. I think this review of literature, it just shows different case series, so it is not special. But sometimes you can do a repair in these cases where we have a partial repair. In this paper, I think they have nine patients, and they did an intraoperative mortality test was 0. I think they had only a partial repair was in this series, so they repaired this all the cases, and I think the results were excellent. So emergency mitral valve replacement is the treatment of choice, but repair typically patient is with partial rupture and stable hemodynamics. Concomitant CABG can be performed to achieve the optimal revascularization with similar operative mortality to mitral valve surgery alone. In patients who are contraindication, and heart team approach is an important part of management. So transcatheter edge-to-edge repair, we can do edge-to-edge repair, and temporary mechanical circulatory support in patients who are sick. And then we can put them on a ventricular assist device, which can be LVAD, and even later on the heart transplantation, which can be done in even in VSR or any other mechanical complication. So this was regarding the papillary muscle rupture. Any questions with this? So this is pseudoaneurysm, basically is a late presentation and of a pre-war rupture. I will present couple of cases. Electroventricular pseudoaneurysm is a contained cardiac rupture, which is a type 3 pre-war rupture. The pseudoaneurysms contain no endocardium or myocardium. They are prone to rupture. That is why we have to operate upon them. Usually the etiology is acute MI, but the aneurysm may occur post-cardiac surgery or trauma or infection. The commonest site is inferior wall is the commonest site. Timing of presentation, it could be few days to several years after the acute MI. Because of its rarity, the natural history of ventricular pseudoaneurysm is unknown. Rupture with fatal extranjation is not inevitable. Presence of pseudoaneurysm itself is an indication for surgery, unless contraindicated, because there is a fear of rupture. These patients may be asymptomatic, and they may present with heart failure. They may have chest pain, ventricular arrhythmia, systemic embolization, and sudden death. So two of our patients, she came with heart failure, and another he came with stroke. So ECG shows ST changes from the, we have ST elevation. which are non-specific. X-ray may show cardiomegaly. Echocardiography is the most important diagnostic tool. LV angiography is also helpful. I think that you should do in these cases, I strongly recommend we should do a CT and MRI of this patient just to describe the anatomy in detail to plan your surgical repair. This is one of our patients, in this picture you can see, this is an LV and this is the LA and this is the aorta. You can see the pseudoaneurysm, which is bigger than the LV. It was a huge pseudoaneurysm. And you can see there was a small connection between the LV and the pseudoaneurysm. This is another patient. So he has an, it has an posterior apico-inferior large pseudoaneurysm. This is LV, and his it is a big neck, large neck, and this is the aneurysm. This patient had a clot in his pseudoaneurysm, and he came with a stroke. So when you do a CT, you can appreciate a large, pseudoaneurysm. You can see this is an LV, and this is a whole is a pseudoaneurysm with a large neck. So this is another case that which has this is a pseudoaneurysm. So these cases, untreated pseudoaneurysm have a 30 to 40% risk of rupture, has been reported in, but the literature is very old. I think from the recent literature, I think Mayo Clinic, it is not that common. I think it is very uncommon, their rupture. Surgery is the preferred therapeutic option. Percutaneous transcatheter device is an alternative to conventional surgery in high-risk patients. Two different approaches are used to repair the pseudoaneurysm: primary repair and patch closure. And I think that is it. I'm not sure I have some more. You have any questions? Okay. This is the case, it has a large pseudoaneurysm. And then we did an aneurysmectomy with linear closure of the neck of aneurysm. He did well. This patient he presented with a stroke. And you can see we excised his pseudoaneurysm and then did a linear closure. They have a very good tissue to stitch. Okay. So this was a brief about the mechanical complications of the acute MI. So if you have any questions, I'll be happy to answer. Hello? Can you hear me?
Yes, so we can hear you.
So basically, there are no guidelines. This is a very unusual topic. So here the personal experience matters, and how is your center? It matters. Whether he's accepting these sick patients or not, and so this opinion may vary from person to person. I'm not sure what examination questions you will get from this topic and what will be discussion. So personally, I will say all mechanical complications are rare. Now the tendency is to put them patient on mechanical circulatory support, but the literature says there has not been benefit. So in short, remember these complications, and management is tailored as per the patient need.
Thank you very much, Dr. Shabir, for your time. It was very, very well illustrated topic and very nice review. Thank you again.
Yeah, if you have any questions in the future, just text me or just call me directly on my phone number. Anybody can approach me anytime. Actually, we are doing one. There's a caution study It is a multi-center study with the European centers. I think 15 centers were involved. Our center is one of them. And we have submitted 2 papers. One is VSR and another is pre-war rupture. One of them is accepted already in the JAMA. It is 130, I don't remember the number, 135, 140 cases. And there is VSR, which has some 400 cases. This is the largest series. And one paper has been accepted. It will be soon, soon it will be published. Whenever it published, I will share with you guys. And VSR is also under consideration for publication, not accepted yet. As soon as it is done, I will share with you guys. Thank you very much.
Thank you again, Doctor. We're supposed to have a mock exam, but with Dr. Rakan and Dr. Fahad, but maybe we can talk to them another time. As you saw, Dr. Rakan, he said he was busy and he prepared some of these cases, the catastrophic aortic cardiopulmonary bypass scenario. So by this we end today, and inshallah tomorrow morning we'll start at 8 o'clock.